the compliance of lungs. So when we talk about disease-specific ventilation, many of these factors change, and these are how we will kind of change our parameters of ventilation to help do it more correctly. So compliance is something which is, as you can see, the distensibility or the stretchability, and this becomes significant. If the baby is going to be breathing and the chest compliance is good, and if the baby is breathing and then as the chest expands, the muscles take action, there's negative intrapleural pressure created, and if the baby is breathing, then the intrapleural pressure increases. So these are various factors that we need to kind of understand. So change in lung volume per unit change in transpleural pressure. So in simple terms, and lungs are quite compliant, and the compliance changes with various neonatal diseases, and we shall see in the further slides how this change is kind of affected. So as you can see that in the neonatal lung, the compliance changes differently. So there is low compliance in RDS, and there is a high compliance in chronic lung disease. There is compliance is low at low lung volume. We'll see that in a slide in more detail a little bit further. And compliance falls even at higher lung volume. So depending upon lung volume, at low lung volume and even at higher lung volume, the compliance tends to fall. So as you can see in this particular, so over here you have poor compliance, and again over here you have. This is the best part where you kind of ventilate. So this is more clearly seen in this what I call as the pressure volume curve. So when there is over expansion, you are not able to ventilate properly, and when there is low FRC, again you are not able to ventilate clearly. So this is the FRC that you should try and achieve. And if you look at the figure on the left, you have compliances for the lung and compliances for the chest wall, and we need to be aware of how they can be different. So this is your residual volume, what we saw in a slide a few slides back, and this is your closing or collapse volume. So these are few terminologies that we need to understand. So these are in many ways things that we have to understand when we are using ventilators, and if you don't have a grasp of the basics, it can be difficult to understand what is happening in a particular lung. And this is a dynamic stuff. This keeps on changing on a day-to-day basis and an hour-to-hour basis, depending upon the condition of the lung. So as you can see, this is your RDS lung, and there is a very little difference between the expiratory and inspiratory limbs. And while in a normal lung, there's quite a significant difference which is happening. And this is the part of the area that we are interested in targeting and achieving, so that we have good expansion with minimal effort or minimal issues. This is what we talked about, the elastic recoil of the chest wall, and how kind of as the chest wall expands and then recoil, or when it in expiration, it's kind of automatic way that it happens. Another part is where this is what is the Laplace relationship and the effects between surfactant, film, and alveolar ventilation. So if you look at the figures on the A part of the screen, this is with surfactant, the pressures required are lower, and if there is no surfactant for whatever reasons, the pressures that are required to expand are higher. Similarly, on this side, you can see as the radius drops, there's this alveoli collapse, there's a small radius, then the pressures are higher, and the pressures are if the radius is bigger, then the pressures required are lower. So these are kind of shown the formula over here. 2 is equal to 2 surface tension divided by radius. So surface tension and the radius both kind of decide the amount of pressure required to expand the alveoli. We'll not be talking about VQ mismatch today in my talk, but that is something else also that we should be considering. So we looked at compliance, and the other factor that we commonly need to look at also is resistance, and it also viscous resistance, or what is because of the tissue because of lung tissue, and this is higher in neonates as compared to adults, and higher in disease lung as compared to normal lung. So this is the one that is generated by the tissue elements. Airway resistance is again that happens between moving molecules of the gas and between the respiratory system. So these are two kinds of resistance that we should be looking at. And this is something, and in addition to that, if your ventilator circuits are not good, and they also can contribute to extra resistance. So this is your inherent capacity of the air conducting system, as we saw earlier. And again, delta pressure upon delta flow. This is another concept that we should be understanding when we're talking about understanding the basics of ventilation. So compliance, resistance, and as you can see, the resistance changes positively with more compliance area, and as the length of the airways increase, the flow rate increases, and as the density and viscosity increases, that resistance can kind of worsen. So this is something which we should be aware of. So in this slide, you can see that high resistance means a high inspirator pressure or long expirator time. So in CLD, it's high resistance and high compliance, and in an RDS lung, it's low resistance and low compliance. So this is in many ways how kind of resistance works. And where is the airway resistance is there? So the distal airways contribute less to resistance due to there is a very high cross-sectional area, while a smaller ETT and high flow rates, as we saw in the slide previously, they can increase resistance markedly. So just to remind you, so this is what we're talking about. Okay, length of airways, flow rates, all this can increase resistance markedly. So distal airways contribute pretty less to resistance, and as you can see, as the distance increases, your resistance kind of drops. So once you know compliance and resistance, we also would look at time constants. And so time constant is defined as compliance into resistance. So this is a formula which is there, which is fixed. And one time constant is usually the time to exhale about 63% of tidal volume. And 5 time constants is roughly around 99% of tidal volume. As you can see, as your time constants increase, you can see that how much percentage of tidal volume is kind of exhaled. So this is how these are kind of calculated, and this is your calculation which is shown over here. And RDS again has shorter time constants. Same thing which I have shown in a figure format. Okay, as with the change in volume, how many time constants you require for 99% of exhalation to happen. Again, RDS has low compliance and shorter time constant, and CLD has a higher compliance and higher time constant. So these are a few facts which show that how time constants also can be utilized. While we looked at the physics of ventilation and compliance and resistance and time constants, we just look at a few things about the main idea is to kind of ensure that oxygenation happens. And the few a slide or two I showed in the initial part, we're continuing those slides over here. As you can see, this is your alveolus, this is your blood, and diffusion of CO2 happens from the blood to the CO2 in the lungs, and oxygen diffusion depending upon the pressure, partial pressure of oxygen in the alveolus. So this is transfer of oxygen and CO2 between the alveolar and capillary blood. And so these are again the partial pressure of oxygen varies according to the height or the sea level. At sea level, it's around 760. But as you go higher at higher altitudes, and we talk about it in many ways, air becomes thinner. So basically, the pressure drops and the oxygen content actually also drops. So this is the reason why when you go to Leh or Ladakh, you can have issues if your lung health is not good. And this applies to all everyone at higher altitudes. So this is your blood which is coming from in the pulmonary artery, which is deoxygenated, and as it goes through your pulmonary vein and is passing through the capillaries, the diffusion of oxygen that is happening. And while most of the oxygen that is carried in attached to the hemoglobin, almost 99, 98, 99% of oxygen, as you can see over here. This is your alveoli, and it gets transferred to your RBC, and it is combined with hemoglobin, and this is your majority of your oxygen that is getting transferred, and from here it goes to the tissues in the periphery. A little minuscule amount is mixed over here. And why is this important? Because whenever you try and increase FiO2, this expands a little bit more. And if this is already a lot of oxygen is already combined, it does not add anything more to your oxygen carrying capacity. And so oxygen content of blood is kind of shown in the formula over here with hemoglobin and your saturation. So as you can see over here, this is how your content, oxygen content of blood is kind of calculated. A simplistic form at the capillary end. So this is your arterial end of the capillary in the tissues and in the venous end. So this is how your exchange or oxygen is lost from the arterial side of the capillary into the tissues or transferred to the tissues, and carbon dioxide is picked up. We're not talking about carbon dioxide right now, but this is oxygen which is happening. Now, another part of the equation. So this is all basically physiology that becomes very important when we're discussing as to whether oxygen transfer is happening or not. So this is your hemoglobin oxygen dissociation curve. Again, required to ensure that if in a baby with fetal hemoglobin, higher fetal hemoglobin, preterm, etc., it shifts to the left. So it kind of retains oxygen much more easier. But when you go the periphery, when there is decreased pH in the tissues, etc., then oxygen is transferred more easily to the tissue. So your shift to the left or the shift to the right of the oxygen dissociation curve becomes important when you're considering transfer of movement of oxygen from lungs to the tissues and how much it is getting transferred. So this, as I mentioned, shift to the right can happen in acidosis, increased CO2, increased temperature, and increased DPG or biphosphogluten. So these are various indices that we need to calculate, and it has to be calculated on a daily basis when you're seeing patients, or maybe the patient's status is rapidly improving or deteriorating. Then also you need to do it at every ABG. So these are your arterial alveolar oxygen tension ratio, and it's almost close to 1 in a healthy infant, and alveolar arterial oxygen gradient. So these are again gradients which are to be utilized. So it's less than 20 in room air. Oxygen indices have to be mentioned in every file of a patient who's getting ventilated, and anything more than 15 shows that the patient is having issues, and you might need to improve your ventilation pressures, etc. And if it is reaching around 40, then maybe you are in for ECMO. So, and it also suggests that you have a higher mortality rate. So calculating your oxygen indices becomes very important, and it depends upon your mean alveolar pressure and FiO2. Now, this is how we increase oxygenation. So increasing your PaO2 by increasing FiO2. So this is just increasing FiO2 will increase your alveolar tension of oxygenation, which causes more oxygen to shift to the capillaries. Optimizing VQ performation of VQ match or ventilation perfusion matching is also important, and maximizing pulmonary blood flow. So we'll be discussing how we kind of increase your MAP. So your mean airway pressure is dependent upon these 5 parameters, and this is the most important part of how we go about improving oxygenation. Your inspiratory flow, how fast the curve rises, and it becomes important. Increasing pressures will also improve your oxygenation. Then your inspiratory and expiratory time. So increasing your inspiratory time can also increase your oxygenation. Increasing peak also improves your oxygenation, and peak and expiratory pressure. And again, so your I ratio is all kind of increasing your ventilatory rate. So the last thing is the ventilatory rate can also reduce the expiratory time without changing the I time. So these are the respiratory rate, PIP, PEEP, okay, inspiratory flow, and your I time. So all of these kind of can increase your mean airway pressure. The most important point to realize is PEEP is the best way to increase your MAP, and increasing your MAP also increases your oxygenation. So this is something that we should understand. So 2 and 4 would contribute to some extent. The rest of the parameters do not really contribute much to your increasing oxygenation. So I'll try and explain it in a better format over here. So the same thing which was there in the previous slide, it tells you which of those increase your oxygenation. So increasing oxygenation is more or less directly related to increasing PEEP. Okay. So next, so this is generally considered as oxygenation, and when you talk about ventilation or CO2 removal, we are interested in respiratory rate. So increasing respiratory rate causes a CO2 washout, and also directly related to your minute ventilation. So if your tidal volumes are higher or your respiratory rate is higher, it ensures that your CO2 washout will occur, and CO2 removal is kind of made easier. So respiratory rate, as you noted, also increases oxygenation, but whenever you increase respiratory rate, you're more likely to wash out CO2 rather than increase oxygenation to that extent. So that's something we should kind of understand. And tidal volume can be increased easily by increasing PIP and reducing PEEP. And reducing PEEP will again decrease oxygenation. These are all interplay of various features that will happen in improving oxygenation or worsening oxygenation. These are all things we should kind of be aware of when we are trying to ventilate a baby. So this is your ways to wash out CO2, either increase PEEP or reduce PEEP, so that ensures that you have a higher tidal volume. In the next few slides, so we have covered so far a little bit of physiology, understanding volumes and capacities, compliance, resistance, and a little bit of how oxygen moves from the lungs to the blood, and how it becomes important, and what parameters can improve oxygenation or washout of CO2. We'll go next to what are the parts of a ventilator. So as you can see on the screen, it's kind of pretty complicated. So your oxygen and air supply, as you can see here. Okay, so this is here. Then it goes to the blender. You have an inspiratory valve, as you can see. Then you have a flow sensor, a humidifier. Okay, and then you have a controller, and then you have your PEEP, which is there. So this is your various parts, and it looks pretty complicated. So I'll just show you in kind of a flow. So this is how baby is getting ventilated. So inspiration and expiration looks a pretty complicated way of how a ventilator works. Okay, but in basically, if you want to think, it's just a T piece. Okay, so oxygen is coming from here, and then it goes out here, and this is the patient end. If you close this, the oxygen will go to the patient. When you open it, there will be flow from this side. Okay, as you can see here, with your exhalation valve open, okay, at this part of the T piece, the exhalation will happen, and when exhalation valve is closed, you have inspiration which is happening. So this is kind of at the basic. If you want to understand what it is doing, it's basically like working like a T piece, and the different ventilators have different settings and so many other things, and all those settings, etc., will kind of modify stuff a little bit here and there. So that's what we need to kind of be aware of. Humidifier becomes very important. If you look at bigger children or even adults, many of them do not use humidifiers, and they use what I call as HME exchanges. And we should never use ventilators in units without humidifiers, because that kind of will damage the lung in various ways. And so it's important to, as you can see over here, the humidifier, we will ensure that the air is heated and humidified, and then it is supplied to the baby. So there are various ways, and as you can see, 45 milligram per liter is the best humidity which is available, which will be the optimum range. And as it drops, you have various harmful things that are happening, like thickened mucus, adverse cilia, etc. I will now skip all the slides which are related to modes of ventilation, which Madam is going to be taking, and I'm just run through the slides. And these are the stuff which she will be taking further. Triggers and so on and so forth. Cycling and so on and so forth. That brings me to my final slide. So it's if you want to really understand ventilation, you have to understand the physiology of breathing, how air exchanges take place, how oxygen is transferred, and a few basics of the ventilator, how a ventilator works. And unless you get that part correct, you are unlikely to get ventilation correct. So understanding the physiology, the various time concepts, etc., becomes extremely important. So this is in short, basically how oxidation kind of happens. I'll leave you a few pictures of our team. This is our DM neonatology team in Karamsad. This is our team in Anand, where we have worked together to do a state conference in 2016. And we are going to have a state conference again. The same team will be doing, and you can see many people over here. Dr. Ashish Mehta, Dr. Mohit Sani, okay, Biraj is here. So many of us are working together. I think I have finished in time, and thank you very much. I'm sorry it went fast, but I think we would better have interactions on the table. That would be best. Thank you.
Thank you so much, sir, for an immensely valuable concept on lung mechanics. Next, I would like to request our mentor and guide, Dr. Anita Singh Ma'am, who is specialist in neonatology with approximately more than 10 years of clinical and academic experience. Ma'am is key facilitator and mentor to several research projects. Ma'am is also a national NRP trainer and member for National Neonatal Database. Ma'am has over more than 40 publications in index journals and has co-authored over more than 30 book chapters. So I would like to request Dr. Anita ma'am to please illuminate us with talk on modes of ventilation. Over to you.
So thank you very much, Preeti. So after the talk on physiology, which discussed so many important parameters, which we really need to understand if we have to ventilate optimally. So coming to the modes of advanced ventilation. So I would like to first ask how many of you are using which mode of ventilation? Who are the people that are what are the modes of ventilation they are available with? Come on, this is an example. So are you using ventilation or there are two like so it's a commonest not ventilation we use. So I can see that most of the people who are I would say they are having one of ventilation is the commonest mode of ventilation in which we are often found whether we go or we very good meeting. And it is I think we are more often so in this presentation, I would like to discuss about to understand the concept of the variables which define growth. So if you want to understand the mode of ventilation, we really need to understand how the method is started, what are the limiting factors, and how the method is started. So this is important to understand. If we understand that, then only we will be able to know about various mode of ventilation, because often we are fascinated with the newer mode of ventilation, advanced mode of ventilation. We really think that this mode of ventilation is wonders, but at the end of the day, it is the person behind the modes or machine which is important. So next important thing would be to know where to use which one. So this was very well explained in the previous lecture that when all ventilators, mostly they derive gas flow from the central source. They adjust it to some pressure and mix the gases to the blender, as we require some air and some FiO2. So air oxygen mixture is done, and then via a flow regulated valve, it goes to the patients, and once the inspiration is terminated, there is exhalation, and which is regulated by exhalation valve. There are several factors with what determines the positive and expiratory pressure and other things. So this is how a breath is. Like, we have a time, we have a variable which can be either pressure or volume. In the neonatology, mostly it is the pressure control ventilation. So here it is the time, then a breath is initiated, it is the inspiration. Then once the destined inspiratory time is achieved, there is exhalation, and it turns to the baseline, and again a breath is started. So how and what is the type of breath? To understand that, we need to really understand what are the various breaths. So there is a machine, there is a patient, and both should have some interaction. So either can be completely ventilator driven, either it can be a patient driven and assisted by the ventilator. So when patient initiates a breath and ventilator controls it, and subsequently there could be a spontaneous mode which happens in the NIVs. So in the understanding of the mode, most important three things are that each breath, what is the factor which would lead to the initiation of breath? That is called as trigger. Then how is the control? How much breath is to be going there? Patient ko kitni saans aani hai? That limit. So that is the control variable is limit. And then the third one is the how would be the inflation terminated? In understanding of the mode, it is the inspiratory part which is the most important and which is often controlled by the ventilators. Often the exhalation becomes passive. So how the inspiration would be terminated? That would be the cycling. Ventilator has to cycle to the another breath. So that would these three things are trigger, limit, and cycle. So these we call as a phase variable. Trigger determines the inspiration to begin. That is at the A part. Here the breath is being initiated. So ventilator has to know when I have to start a breath. So we would see how it does. Then other factor would be the limit. So what regulates gas flow? In the ventilation, we push the gas, a machine push the gas in the patient's lungs. So how the gas flow occur during breath, that is determined by B. So B is the part, this portion is limit. So limit could be either a predetermined pressure. We want to breath to be a particular level of positive PIP, that is peak inspiratory pressure, or it could be tidal volume. And then at the end of the inspiration, there would have to be cycling. So patient has to know when I have to cycle. The machine just cannot keep pushing the gas flow inside the lungs. So there has to be some cycling mechanism till when patient has to receive the flow. So what causes the breath to end is the cycling variable. So let us first start with the trigger. So it initiate inspiration, and in the mandatory breath, most often it is a time trigger ventilation. Like we have set up a rate of 30. So every 2 seconds, machine knows that I have to give a breath. Every 2 seconds, I have to trigger. There are trigger windows, and every 2 seconds, machine would initiate a breath. Then there are patient trigger breath. Patient trigger breath, we have to understand that these patient trigger breath always work on the basis of flow sensor. We have to have a flow sensor, and the machine detects the change in flow or pressure. Then it senses the pressure change, and then it determines that I have to initiate a breath. I have to start a breath to the patient. So change of pressure or flow would be sensed by the ventilator, and it initiates a breath. So a trigger can be either ventilation decided by the ventilator or by the patient. So let us understand the time triggering. So we have a trigger window of 3 seconds. So, say hypothetically we take a breath rate of 20 breaths in a 1 minute, then every 3 seconds, ventilator knows that it has to give a breath. So it has maintained this trigger windows. This is the one trigger window, another trigger window, and uh, every 3 second ventilator knows that I have to start a breath. So it is determined by the machine and at a preset interval. So in this slide, what we can see, there are trigger window of 3 seconds, and in between, there are some breaths which are initiated by the patient. So the magnitude of this spontaneous breath would not be as such as per the ventilator strength. So these are the small spontaneous breaths which are occurring between the trigger windows of the one ventilator breath. Then once the patient start triggering, the ventilator would sense the change in pressure or flow in the circuit, and it will start the breath. So in this arrow, there is a change in the pressure or flow, which ventilator has sensed, and it has given its own breath. Then after that, baby is breathing. So ventilator knows that I have to give 20 breaths to a particular strength, which has to be taken care. So this is initiated by the patient, but assisted by the ventilator. After that, if the baby wants to breathe, baby is breathing. Again, ventilator would wait that at the end, it saw that patient initiated one breath, and again at the end of another trigger window, it is not causing any sense. Suppose if the baby is not initiating any breath or trigger, then ventilator would again give a breath. So this is a mandatory breath. Again, here patient has made an effort, which ventilator has sensed. So ventilator knew that in 3 seconds, I have to give 3 breaths of a particular strength, which has been said by the user. So these 3 breaths were given by the ventilator. So this is how it works. If the patient has initiated, ventilator would assist. If not, then ventilator would do it by time triggering. So here how it happens that patient is triggering and being assisted by the ventilator. So what we have to do with the trigger? Does anybody set the trigger in the ventilators which they use? Anyone? So as we have understood that trigger is something which has to be initiated by the breath, and often it is the ease of the patient trigger which ventilator has to sense. So if the baby is sick, we don't want the patient to exert much to determine to sense by the ventilator. So in case of the patient is sick, we need to set the trigger at the low sensitivity, very high sensitivity, and if the patient is being weaned, then we can change the trigger accordingly. So we have to have a spontaneous trigger, then in that case, there are flow trigger or pressure trigger. A flow trigger is more sensitive and more physiological. Then next variable coming to the limit. So limit determines what regulates the gas flow during the breath. So in the ventilator breath, there is a gas flow. Air oxygen mixture is being pushed by the ventilator inside the patient lung. And variable could be limit, like pressure. So we know that there is a peak inspiratory pressure, that is PIP. Then there is a flow rate, and there is a volume, that is tidal volume. So it could be PIP, it could be the flow rate, or it could be the tidal volume, which is allowed to go up to some extent, allowed to rise above the preset value during the inspiratory time. And once it achieved, it is set at there. And after that is the limit. So ventilator knows that this limit has achieved, and I don't have to keep on pushing the lungs through the gas. Even if the inspiratory time is there, ventilator knows that I have to keep the lungs distended to that preset pressure, or to inflate the lung to that pressure tidal volume. So this is the limit which determines the magnitude of the breath, and it holds the breath to that level. So this is a kind of limit where the pressure is constant. We can see this bar where we want that this has to be limited. So in each breath, we want that the peak inspiratory pressure has to be limited up to this, and the volume can vary. So ventilator knows whatever may happen, I have to give the breath with this much of pressure, and the volume can vary across the breaths. Another one is this: when we set the time volume as a limit, then pressure can vary in between the breaths. So here is the role of limit, how these are the limit variables. for a particular breath. Then coming to the cycling. Now when breath has started, it has to be pushed. The gas has been pushed in the baby's lung, and now ventilator needs to know that when I have to initiate the exhalation. So for the exhalation valve has to open and the gas flow has to cease. So this is called as cycling. So this variable, the variable which signals the ventilator for the cycling and the termination of the inspiration and initiation of the exhalation is called as the cycling variable. So the ventilator can cycle at the time. So if we have set a preset TI, ventilator knows as I have to give this flow rate, gas flow to that much of PIP and 0.4 second if it's the TI. So ventilator would cycle the breath at the end of the 0.4 second. So that is what is called as time cycling. Then there could be a flow cycling. So we know that there is a flow rate. Rates are in the liters per minute. We will understand that more in the graphics. So the flow rates are there. So then there could be a cycling. So a particular flow rate is achieved, and then ventilator knows that if this much of flow rate is achieved and it is decelerating, I have to end the inspiration and start the exhalation. So that is called as flow cycling. And then there is volume cycling also, in which the particular tidal volume is taken as a cycling variable. So coming to the time cycling first. So these are two graphs. This is a pressure time scalar and this is a flow time scalar. So we can see that ventilator has been giving a pressure to this PIP limit to this TI time, and this is a flow graph. So we can see that flow rate has ceased. Ventilator has given the flow, and now patient's PIP is achieved, but ventilator has been given a command that it would not allow the baby to exhale until this TI is achieved. So baby's lung would remain inflated to that much of duration, and then exhalation would start. So the cycling would start after the preset TI. So this is just a time cycling. Then coming to the flow cycling. So again, we have a pressure time graph and this is a flow time graph. So flow rate is like if once the gas are pushed into the baby's lung, there is a flow rate. So it first goes to the peak and then it starts decelerating. And this is the peak flow rate. So as the peak flow rate goes to 10 to 15% of the maximum value, if we set it as say it has 100% peak, and this is we can say this could be taken as a 10%. So ventilator is given command once the flow rate is achieved to the 10% limit, it will open the exhalation valve and exhalation is started. So this is called as flow cycling. So here you can see that baby's lung are not being kept in a particular distended state because we have set some preset TI time. Here that inspiratory time is being determined by the patient's lung mechanics. So this is a time cycle phase where you can see there is a gap between inspiration and exhalation flow. And in case of flow cycling, it is a smooth curve. So coming to the modes of ventilation, once we have understood the trigger, limit, and cycle, which are phases of the breath or variables of the ventilator breath, then we can understand very easily what is the mode of ventilation and how it works and their relative pros and cons. So the mode of ventilation refers to the sequencing or pattern of breath delivered to the patient based on the above three variables which we discussed in the previous slides. So the conventional mode of ventilation include controlled mandatory ventilation, which is just always discussed in the mode of ventilation class, but nobody uses this. Then there could assist control ventilation, SIMV mode of ventilation, this is synchronized intermittent mandatory ventilation, and pressure support ventilation. So the controlled breath that is totally controlled by the patient is IMV or CMV, and then the spontaneous breath or patient trigger breath are SIMV, assist control, or PSV. So coming to the mandatory IMV first, these were the primitive kind of mode where patient mandatory breaths are delivered at regular interval based on the set breath rate. And if the patient wants to breathe in between the breaths, ventilator breath, it becomes a asynchrony. So this ventilator would start giving the breath irrespective of the patient effort. Whatever patient is breathing in between, it would not sense it efforts and it would not synchronize it, and it will just keep giving the breath as per the set ventilatory rates. So this is the mandatory breath. This is the mandatory breath, and here the patient is breathing. But if the patient wants to breathe here, it will not sense and it will keep on giving breath as per the given command. I would say if somebody is not using flow sensor, any mode of ventilation is IMV. So if we really have to optimize our ventilation as per the mode, we have to use the flow sensors optimally. So what we can see in the intermittent IMV mode of ventilation, that breaths are given by the pressures, the breaths are given at the preset interval, the time between the breaths are fixed, and there would be a lot of asynchrony, which will lead to variable tidal volume across the breaths. So obviously, this doesn't seem to be a very good choice. So it has a lot of disadvantages: asynchrony, ineffective gas exchange, fighting with the ventilator, gas trapping, and air leaks. So next is the SIMP mode of the ventilation, which is the most widely used mode of the ventilation. To best describe what we call as time cycled and pressure limited. So most of us we know that in the neonatology, mostly we are using pressure limited ventilation. That is, we set the PIP, we set the PEEP, we set the TI. So this is a pressure limited ventilation, and it is a time cycle. So the duration of the breath is determined as per the set TI. So time cycle pressure limited mode that provides a set number of mechanical inflation. And here synchronization is happening. The S means for the synchronization, that ventilator knows that I have to synchronize the patient spontaneous effort and then allow the efforts to go up to the given magnitude. However, the patient is allowed to breathe spontaneously in between. There is a trigger window. So as per set rate, there would be trigger window. If the rate is set as 20, the trigger window would be 3 seconds. If the rate is set as 30, the trigger window would be 2 seconds. So if no spontaneous effort is detected during a trigger window, a mandatory inflation is given. Otherwise, ventilator wants all the efforts to synchronize the inspiration with the patient effort. And spontaneous breath in excess of the set ventilator rate are not supported. So here we can see SIMV during spontaneous breathing. So this is the respiratory cycle time. That is a one cycle time which ventilator knows that I have to have this time. And here patient has started a breath and ventilator has sensed it. And after that, if the patient has some respiratory effort, patient is breathing spontaneously. Then again in the next trigger window, a breath is started. So if we see in this lower slides, here what is happening, a breath is initiated and ventilator has given it to the supported it. Then somehow baby is not breathing in another trigger window. So it saw that not breathing. So it is given a mandatory breath. So during all respiratory cycle, the microprocessor inside the ventilator set the trigger windows and keep on checking that I have to give 30 breaths if it has been set of the same magnitude. And if the patient would initiate a breath in that trigger window, I would give that breath to the maximum effort and rest of the breath would be taken by the patients. So this is how, so you can see that during a whole cycle, there is a mandatory minute ventilation happening and there is some spontaneous respiration happening, and ventilator is trying to synchronize the inspiratory effort with the ventilator breaths, and the cycling is the happening by the time. Inspiratory time is set and ventilator knows that I have to give the breath to that time. So in the SIMB, the breath to breath time may not be set. Like in the IMB, you know that between the two breaths there would be a set time, but here it is not a fixed time. If the patient has initiated a spontaneous effort, ventilator knows that I have to give this breath. So, and the tidal volume would be more effective and better than the IMB. Which this one, yes. This one, this you want to ये वाला हाँ ये yes, because वेंटिलेटर डिटेक्ट सब कुछ कर रहा है, बट उसको पता है कि उसको सारे ब्रेथ सपोर्ट नहीं करेंगे. वी विल सी दिस फर्दर मोड ऑफ वेंटिलेशन इज कंट्रोल. हियर व्हाट इज हैपनिंग दैट हमने वेंटिलेटर को एक कमांड दिया है कि आपको 1 मिनट में 30 ब्रेथ देने हैं. ठीक, हमें 30 का साइकिल, वैसे 30 थोड़ा कम है नियोनेट के लिए, लेकिन हम अंडरस्टैंडिंग पर्पस के लिए 30 ले लेते हैं. देन वी नो दैट इन ईच 2 सेकंड वेंटिलेटर को पता है कि हर 2 सेकंड में मुझे एक हाइपोथेटिकल सिचुएशन लेते हैं उसमें आपको 16 का पीआईपी चाहिए, 5 का पीक चाहिए और टीआई 0.4 रख लेते हैं. तो वेंटिलेटर को पता है कि हर 2 सेकंड पे मुझे एक ब्रेथ ऐसी देनी है जिसकी पीआईपी 16 होगी, जिसका टीआई 0.4 होगा. उसके बाद बच्चा जो भी ब्रीथ कर रहा है वो ब्रीथ कर सकता है. तो पूरे 1 मिनट में उसको इतने ब्रेथ देने हैं, लेकिन वो 1 मिनट के 30 सेकेंड्स में वो सारे ब्रेथ साथ में नहीं दे देगी. देयर इज अ सिंक्रोनाइजेशन. इट हैज अ ट्रिगर विंडो. उसकी एक ट्रिगर विंडो है 2 सेकंड की. वो 2 सेकंड में उसे पता है कि एक ब्रेथ देनी है और अगले 4 सेकंड के बीच में मुझे वेट करना है कि वो बच्चा सेंस है. उसको पता है कि मुझे अगर बच्चा एफर्ट लगाएगा तो मुझे उसको सिंक्रोनाइज करना है, मुझे बच्चे से फाइट नहीं करनी. Ventilator knows that he doesn't have to fight with the baby, so it would sense the inspiratory effort. So in each trigger window, it wants to give a breath which has magnitude of what we want to give. Apart from that, these are also being sensed, but उसको पता है कि इसको मुझे support नहीं करना. So sensing is one thing, but supporting is another. उसको कितने breath support करने हैं, कैसे support करने हैं, that is being determined by this trigger window, right?
इसमें मतलब जो बीच वाला ये इसके ऊपर है, ये इसका रेगुलर इंटरवल के बीच में फटाफट आ गई है और उसका मैग्नीट्यूड भी स्लोली जो वेंटिलेटर फिगर है.
आपने ये देखा कि ये प्रेशर ग्राफ है, ये फ्लो ग्राफ है. ठीक है, प्रेशर ग्राफ में हम स्पॉन्टेनियस ब्रेथ वी कैन नॉट डिटेक्ट लाइक दिस, जैसे आप फ्लो में देख रहे हैं स्पॉन्टेनियस, बट ये छोटे छोटे फ्लो में देख रहे हैं. ठीक है, ये प्रेशर ग्राफ है, ये फ्लो ग्राफ. So these are the spontaneous effort. This is the mandatory breath. This is a mandatory breath. This is a mandatory breath. ये mandatory है, ये mandatory है, ये mandatory है, ये है.
क्योंकि मैग्नीट्यूड डेप्थ का इंटरवल जो है इसमें थोड़ा बीच वाला फटाफट होगा, बाद में स्पेसिंग आ गई.
तो इसमें भी तो ऐसे ही होगा, बाद में स्पेसिंग आ गई यहाँ पे.
लेकिन गैप और बीच वाले में गैप हो गया तो अगर मैग्नीट्यूड पर उतना फिक्स करना है.
मैंडेटरी नहीं है, सिंक्रोनाइज इंटरमिटेंट मैंडेटरी है. सिंक्रोनाइज
इंटरवल को फिक्स करना है, बाकी
नहीं, इंटरवल फिक्स नहीं रख सकते.
तो जाने के ऊपर उसको पता है वो भी वो जो सेकंड व्यू है वो फटाफट आ गया. मैं कैसे बोलना the machine or motor has been set in such a way to last 15 seconds so that इसकी window में the machine would try to give the breath the patient is initiating. The machine is going to wait for that duration, last 15 seconds. There is no breathing initiated, the machine will 50, sorry, last 50% of the cycle. Whatever cycle you have set, last 15% of the cycle, the machine, if there are no breath, then machine is going to give that breath. Okay, but then another 2 seconds machine is going to wait. Okay, and in that case, why there is a problem? Because there is the initiation of the breath at last 15% of the second, so the interval vary करेगा. But there is no breath to mandatory breath यहाँ to vary करेगा. Another thing, if the duration is increased, suppose I have given an order to give the 30 breath in 60 seconds, so हर 2 seconds पे करना है. तो duration बढ़ जाए तो अभी 30 की वजह से क्या जाएगा 29 हो जाएगा. Because machine waited for one breath to be initiated, but my order is to give the 30 breath. So next time में just वो 2 पीरियड के बीच का duration कम करके machine will keep it sure that the baby is going to receive very tiny cycle breath. That is why the duration will vary a bit. Because machine initially when करता है कि patient initially करता है कि नहीं करेगा तो ही वो mandatory breath देता. ठीक है, otherwise उसके पास minimize कर देता है.
So, what you ask is correct. So, again,
Very good absolutely right.
if you are thinking that there is mass support, you can go and that is last 50% of the part. At that point, it will support everyone and 30 plus parents, 5 parents. Closer to that second, those seconds closer. Around that point, when it gets bigger, and that point will be big. We have
लास्ट 15% जो साइकिल में यहीं पे ग्रेविटेशन हो रहा है तो मशीन यहीं पे टेक गया है उसके अगले वाली साइकिल में भी वो लास्ट 15% में सपोज यहाँ पे ग्रेविटेशन होता है तो वो वहां पे देगा इसलिए आपका विंडो वैरी कर रहा है बिकॉज़ देखना था और कुछ भी नहीं हुआ लास्ट 15% में तो फिर वो मेडिकली ग्रेड उसके बाद देगा तो विंडो वैरी कर रहा है और इस केस में उसको मेक श्योर करना है कि 30 ग्रेड जाए तो यहाँ पे ड्यूरेशन बढ़ गया तो टोटल 29 ग्रेड हो गई ऐसा नहीं होना दैट इज व्हाई वो पूरा आगे तो टेकिंग द सेट नेक्स्ट डिजिटल सेटिंग जो दिख रहा है आपको ये लास्ट 15% में उसने बेबी पिक कर दिया आपने वो वही पे हां ये उन्होंने खुद से बना इसलिए थोड़ा आपको ज्यादा देरी दिख रहा है बट क्या लास्ट 15% में उसने थोड़ा जल्दी शुरू कर दिया उसको पिक करके दे दिया नेक्स्ट में फिर उसको भी क्या नेक्स्ट वाला पेशेंट है तो उसके अगले वाला है जो किया तो दैट्स व्हाई ड्यूरेशन इज इंक्रीज हाँ ड्यूरेशन 30 जा रहा है ड्यूरेशन बढ़ गया तो टोटल 29 हो गई वो भी नहीं कर रहा है लेटर वक्त में वो भी ड्यूरेशन सेट करके 20 दे
So that is the we want to perceive it as a mathematical calculation, but that is not happening. So ventilator knows its bigger window. Ventilator wants that patient has to. ऐसा ही का concept ऐसे है कि मशीन चाहती है कि बच्चा सांस इनिशिएट करे. So it waits in trigger window कि आप बच्चे को सांस लेना है नहीं लेना है. कभी कभी वो कुछ टाइम में जल्दी सांस ले सकता है, कभी कभी वो थोड़ा रुक सकता है. तो this at the end of the 1 minute ventilator would ensure that उसके जितने आपने रेट सेट किए उतने मैंडेटरी ब्रेथ जाने हैं. सो ब्रेथ टू ब्रेथ टाइम कैन वेरी. ओके, और इन बिटवीन द 2 मैंडेटरी ब्रेथ बेबी इज अलाउड टू ब्रीथ स्पॉन्टेनियसली. Baby may breathe, baby may go apneic for some time. So this is the way. So at SIMB has advantage that there is no need to sedate or paralyze the baby. There is no inspiratory asynchrony, but however there can be expiratory asynchrony. And TI the जो बच्चे के lung mechanics हैं उसके TI shorter हो सकते हैं. We will discuss more so in the other modes. So SIMB is a good mode for the mild to moderate disease. It also helps in weaning and extubation, and tidal volume generated by spontaneous breaths is the indicator of weaning. जैसे हमने यहाँ देखा कि ये tidal volume यहाँ पे कम है क्योंकि spontaneous breath है, यहाँ पे ज्यादा है. So once you see over the days that this spontaneous breath के volume बढ़ रहे हैं, you know that patient is improving. Patient is making good tidal volume, generating good tidal volume by him or herself. So this is how SIMB works. Then coming to the next mode, that is assist control ventilation. The terminology may be different across the different company or brands. So SIPPV is another term which is given by some machines, or it is said as assist control ventilation. So here again we have to understand that these are our patient triggered mode. So triggering to patient की only. Then cycling is determined by the time. So यहाँ पे भी हमारा inspiratory time हम determine करेंगे. It would not be determined by the patient. This is a patient limited mode. But yeah, every spontaneous breath is supported by the ventilator. So here ventilator would sense every spontaneous breath and it would ensure that all the breaths are supported. So rate is decided by the baby. कितने रेट लेने हैं वो बेबी ने डिसाइड किया है. इंस्पिरेटरी टाइम इज डिटरमाइंड बाय द मशीन. All breaths are supported. Or if the patient doesn't breathe, there is a backup rate which is set by the user. That much patient ventilator has to give. So let us understand this. So here what we can see, we have this trigger windows again, and all the breath. यहाँ पे एक ventilator ने breath start की, machine ने उसको दे दिया. फिर यहाँ पे दी. Here what we can see, all the breaths are supported to the same extent, right? Each breath is supported. Ventilator is sensing जब भी बच्चे ने initiate किया उसने start कर दिया. तो if we have set a rate of 30, ventilator would rate तो यहाँ पे patient ने decide करनी है, but patient would initiate a breath and inspiratory time is determined by us. So baby has generated a breath, has generated a trigger here. Ventilator has sensed it, given the ventilation to this much of TI, and then cycled it. So this is how it works. So here आपको क्या समझ में आ रहा है कि mandatory ventilation जो है वो total minute ventilation is more effective. Agar if the patient is not breathing, so what ventilator knows कि उसको अगला मतलब उसको देना ही है, then it works as a IMV, like it is giving a controlled ventilation to in case of apnea. So again, it works like it determines the ventilator, sends the ventilator patient trigger in each trigger window and give the breath. But here all the breaths are supported. In SIMP, all the breaths were not being supported. So here much of the assistance is there. The tidal volume uniformity is there. All the breaths are supported. So it is a good mode for critically sick babies, or whenever you get a very sick baby and you are starting the ventilation. And it can be taken as an initial mode for the sick babies, but problem can be hyperventilation. And you are just not allowing the baby to breathe, and the mandatory ventilation may be high. Then coming to the pressure support ventilation. So इसमें कोई problem है? We understood the SIMP, then we can understand this very well. That yeah, here what is happening, the spontaneous breaths are being supported. All the breaths are supported. Yes, cycling is time only. So here it is very much important that again the inspiration is being synchronized with ventilator sensing breath. Rate is determined by the patient, but TI is not. Rate जो है वो patient decide करेगा. Patient is initiating on the breath, but inspiratory time is determined by the user or machine, right?
There is a margin for set trigger. They have the machine set triggers. Yeah, so if there is static trigger at the lower side, then those breaths won't be detected by the regulator. So that is why we have a bit control.
Yes.
So that we better understand the box.
Yes. Coming to the pressure support ventilation. So again, this is a pressure controlled ventilation. So limit is controlled. Limit is decided by the user. This is a spontaneous mode of ventilation. Here the rates are decided by the patient again, like assess control, but cycling is flow cycling. Here we are not determined. Here we are not controlling the inspiratory time. So cycling is happening because of the lung mechanics, or it is as per the patient spontaneous efforts. So partial ventilator support, in which size of each breath is determined partially by the patient's muscular effort and partially by the ventilator. So here we can see this is the pressure support ventilator breaths. So what is happening here? This is a pressure time scalar or graph, and this is the flow time graph. So this is the limit here we are setting. This is the inspiratory time, and this is exhalation. So here it is the onset of respiration. This is the flow rate. We have to really understand the flow graph to understand the PSV. And what we know that this is the inspiratory portion, this is the expiratory portion, this is peak inspiratory flow rate. And if you see it as 100%, this is around 15% of the peak flow rate. It is also called as ITT, or inspiratory termination trigger, or inspiratory termination sensitivity. So here what is the ventilator is sensing? It is sensing that this flow rate is going to the 15% of the maximum, then it will open the exhalation valve. So यहाँ पे TI, we are not setting the TI. In this case, what is happening? The exhalation valve is opening and exhalation start हो गया when peak flow rate is achieved to the 15% of the say. This can be altered, but mostly एक हम set कर लेते हैं, mostly 10 to 20% or 15% is the good number to set it. So in the breath support ventilation, what is happening? The magnitude of limit is decided by the user or machine, but the initiation of the breath, termination of the breath, both is in the control of the baby. So here it is the PSV, right? So here breaths are supported, breaths are initiated by the patient, and the inspiratory time is also controlled by the patient baby. Any issue with this? So again, it is a very good synchronization. Here we know that patient is not fighting with the ventilator in the exhalation phase. What we say that is in this mode, we have inspiratory and expiratory synchrony both. Decreased work of breathing, less sedation, more efficient tidal volume delivery. But however, in case of patient is having very high rate, say in case of meconium aspiration syndrome or central hyperventilation, all the breaths are supported, and it can lead to hypocapnia or hyperventilation. And there has to be patient effort. So again, in this mode, if the patient doesn't breathe, you have to set a backup ventilation rate. And that would be, if the baby is in apnea, that ventilator would take care of that. So just to summarize, in the case of IMP, there is no inspiratory trigger, there is no assistance, ventilator rates are fixed, inspiratory time is fixed, and PIP is fixed. In case of SIMP, we have inspiratory trigger, which is controlled by the baby. Assistance of each breath is not there, but ventilator breaths are being assisted. And we have fixed inspiratory time and PIP is fixed. In case of assist control, we have inspiratory trigger, assistance of each breath is there. Ventilator respiration rate would vary because if the baby is taking, it will be determined by the baby, otherwise it is a backup rate, and the TI is fixed. In case of PSV, we can say that trigger, assistance, and rate and TI all are being determined by the baby. So a few words about the newer mode. If we understand the basic mode, I can say that we have do maximum judgment to the baby. But just to sum up a few, just to mention a few modes, like we must have heard of SIMV with volume guarantee, volume motion pressure support, PRVC, MMV, and ANAVA, and proportional assist ventilation. So all these newer mode of ventilation are just what they are trying to do. They want to avoid the ventilation-induced lung injury. Whenever we choose a mode of ventilation, either a pressure limited or volume limited, there is another variable which varies. In the pressure controlled ventilation, tidal volume varies. In the volume controlled ventilation, the pressures vary. So some amount of ventilation-induced lung injury is happening. The newer mode of ventilation try to ensure that we try to control both of the things in the set limits. So in the case of volume guarantee, it is a volume targeted time or flow cycle pressure controlled ventilation. It remains pressure controlled ventilation. You have to set a PIP. But what the ventilator does, it chooses a target tidal volume and a pressure limit, and microprocessor compares the axial tidal volume and the pressure inflation. So it adjusts the pressure and pressure in with each breath to ensure that tidal volume delivery is efficient. It is an added feature in the SIMV or PSV, and it ensures uniform tidal volume delivery. As we saw in the SIMV, there was some consistency in the tidal volumes in the breath to breath. So if we add VG, it tried to ensure that this much of set tidal volume would be delivering. Then we have PRVC, in which we can understand more in this graph that ventilator ventilator note that it has to give this much of set tidal volume. This is the set tidal volume bar. It will give a test breath and see how much tidal volume is being delivered by this pressure. It will again increase the pressure in another breath, and it will again increase the pressure so that this tidal volume is achieved. Subsequently, if the tidal volume is getting high, it will decrease the pressure. So it keeps on doing this in each 3 breaths to determine that pressure and volumes are within the desired limits. So again, it is a good mode to ensure the uniform tidal volume ventilation, and it has a better ventilation oxygen matching. So at the end, all parameters need to be set at the initiation, and we need to understand that what we are setting in particular mode and what has to be decided. SIMV and patient trigger ventilation is always preferred, but it would not be happening if you are not using flow sensors. In the sick children, you can start with the sys control. In mild to moderate disease, you can start with the SIMV. Choose a mode in which you are confident. All the babies can be taken care by any mode, be it SIMV, be it PSB, or be it assist control. You need to know the pros and cons and monitor the delivered parameters also, and set the alarms for the parameters which are not controlled. So sophisticated machine do wonders in intelligent minds. So we have to train. It is not only the machine and mode which makes the difference. Thank you. And I think the modes can be better discussed on the station, and the graphics part would be explained more on the ventilator with the testings.
Thank you so much, ma'am, for the very informative session. Now, I would like to invite Dr. Akansha Verma, ma'am, a great orator and mentor, currently working as assistant professor in the Department of Neonatology, SGPCIMS. Ma'am has multiple national and international publications and has co-authored multiple neonatal books. And her thirst areas include neonatal nutrition and non-invasive ventilation. Over to you, ma'am.
Thank you very much, Fazil, for the kind introduction. So as we move ahead, I see that we are already running 40 minutes behind the schedule. So I would just like to have you focus on some of the next topic is initiation and disease specific ventilation. But and the specific learning objectives for this presentation would be preparation for ventilation and principles of disease specific ventilation strategies. So it means that in the next 20 minutes, we are going to discuss how you are, once you have decided that you have to put this baby on mechanical ventilation, how you prepare the baby for that. But then I think the details of this would can be greatly discussed over the workstation rather than discussing them in theory. So I would just give you an overview of that. And for the disease specific strategies, it should, all of you should make it clear that there would be many numbers coming up in the slides. So the purpose of the talk is not to make you memorize and grab all those numbers. It is just that maybe if you get some idea that how we decide on these parameters, that should be a good take home for this presentation. We don't really expect any one of you to remember and just learn all those numbers. So don't go behind those. Just try to understand the pathophysiology and maybe how we can plan our ventilatory strategy. So first, when you have decided, firstly, for preparation of ventilation, the first point is definitely to identify the baby who requires mechanical ventilation, because we know now the era is moving towards more and more non-invasive ventilation, gentle ventilation, lung protective strategies. So first and foremost, we need to decide, does this baby really need mechanical ventilation or not? Then once you have decided that, yes, I am going to intubate and ventilate this baby, how are you going to set up the ventilator? So that is important. Without that, because we in India are not often or do not always have the luxury to have a trained staff who can just set up the ventilator. So it is essential that every person who is ventilating a newborn must know how to set up that ventilator. Then intubating with an appropriate sized endotracheal tube. Obviously, we all of us know. I think most of you are doing junior residency or senior residency. So we know that what is an appropriate sized ET tube for the baby. So if the baby is less than 1 kg, then a size of 2.5 for 1 to 2, 3. And then for babies above 3 kg, you can go in for a 3.5 millimeters tube. Confirm the position of the endotracheal tube. That is must before starting any baby on ventilation or any baby whom you decide to provide ventilation. Confirm it, secure the position of endotracheal tube. An X-ray, first time when you're ventilating a baby, maybe you can do an X-ray or a bedside lung ultrasound to ensure the correct position of the endotracheal tube. But if a baby is being repeatedly intubated, there is no indication to do a repeat X-ray repeatedly. You can just know that on first ventilation that what is the ideal tip or the point or the marker at which the baby endotracheal tube was correctly placed. So you can document that, and then for subsequent intubations, you might not need a repeat imaging every time. Then once your ventilator is set up, you set the parameters, and then also we must always remember, we just tend to push upon we will intubate, we will just resuscitate the baby, we will set the baby on ventilator, but nobody really goes and talks to the parents. But then it is very, very important that once a baby is first time being put on mechanical ventilation, it can be disturbing for the parents. So it is important that you go and counsel the parents regarding the baby's condition. Then, as I just told you, indications of mechanical ventilation could be most often it is respiratory failure, wherein clinically the baby has increased work of breathing with the failure of the modes of non-invasive. Nowadays, I don't think anyone just straight away jumps onto invasive ventilation without giving them a proper trial of non-invasive modalities. But if that has failed, your blood gas is showing persistently respiratory acidosis with a hypoxemia and hypercarbia, yes, that baby needs mechanical ventilation. Or if the baby has repeated apneas or non-invasive, or very often the indication could be shock or a refractory shock wherein the baby is going into requiring multiple inotropes. So there to support the perfusion, the ventilation and the dynamics of the baby, it is advisable that you may preferably ventilate the child. So any baby for any indication, if mechanically ventilated, the goals remain the same: oxygenation and ventilation. So ventilation, I think all of you know, and we have already discussed in the slide on the lung mechanics, that the ventilation depends. What we are mainly talking about is the minute ventilation, that what is the volume of air which is going in and out in every breath. And when we talk about minute ventilation, it is every minute. So it is determined by the tidal volume, that is the volume going in and out, and the multiplied by the rate or the frequency. And when we talk about oxygenation, it is mainly determined by the mean airway pressure, which is based on the ventilator parameters, the PIP, the PEEP, and the TI and the TE that you said, and apart from that, on the FiO2. So this is important that you understand that these two things are different: oxygenation and ventilation. So ventilation, it will mainly target your CO2s of the blood gas, and for oxygenation, it would be mainly targeted, titrated based on the target saturation levels, whether the baby is attaining or not the PO2 levels. So principles of ventilation strategy, there cannot be a single strategy to say that, yes, I give you this strategy and you go and ventilate your baby with this. It has to be condition specific. It always depends what is the underlying disease phenotype or the indication for which you're ventilating the baby, and it will change, keep on changing. If you electively intubated a baby with shock, but then now this baby has got sepsis, this baby has developed VAP, so it will change. The ventilatory parameters, the ventilatory strategies will change with respect to condition, response, and complications. Just a single slide to tell you how to assess or decide ventilation. This can vary based on every individual, but I feel if we have some basic concept or some basic algorithm going on in our mind, it will help us to decide how we can start upon the ventilation. Firstly, whenever we ventilate any baby, we should think what is the maturity of the baby. Are we going to ventilate a term lung or we are going to ventilate a preterm lung? Second is there any possibility of surfactant deficiency for the baby whom you are going to ventilate now? So think about it, because all these things are going to change your ventilatory strategies. Always think about, is there any underlying congenital malformations in this baby or not? A very important thing to consider before starting or setting the ventilator parameters is to know whether it is a normal lung or a diseased lung. कि आप जो बेबी को वेंटिलेट करने जा रहे हो, उसका लंग, अंडरलाइंग लंग इज नॉर्मल और नॉट. दिस इज अ वेरी 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 इंपॉर्टेंट पॉइंट to be considered before deciding ventilatory strategy for any baby. And if it is at all, it is a diseased lung, then you must think what is the underlying pathophysiology. Is it a parenchymal disease? Is it some pneumonia? Is it some MAS which is causing pneumonitis? Or is it some inflammatory condition? Or it is an airway problem as we encounter in cases of BPD? Or is it associated with any pulmonary vascular disease? Because many of the conditions of neonatology often have existing pulmonary vascular problems, which might lead to secondary PPHN, like we know in cases of severe MAS, RDS, CDH. And again, the same thing, if there are any underlying risk factors for PPHN or not. So first condition, the most common condition for which we ventilate in neonatology is respiratory distress syndrome. I think all of you know the pathophysiology of that there is a surfactant deficiency So the alveoli are atelectatic, the functional residual capacity of the lung is less, the lung tends to collapse, the alveoli tend to collapse after every expiration. And because there is no surfactant, so the compliance is less. Compliance and resistance have already been talked about, that we know that how much change in pressure is required to bring about a change in volume, and short time constants. Why short time constant? So we already saw in the first presentation, time constant is how fast a lung can inflate or deflate. So it is a multiplication of compliance into resistance. So we know that in RDS, the compliance is definitely affected because there is no surfactant. So when time constant is a multiple of compliance and resistance, and your compliance is poor, so definitely your time constant is going to be less. The lung is going to fill and empty early. So short time constants. So what do we understand about the lung mechanics? It is a preterm lung that you're going to ventilate. The compliance is mainly affected. The resistance mostly in mild to moderate RDS is normal. There is short time constant and the FRC is reduced. So based on that, we can mode, I think as already Anita ma'am has explained, there cannot be a single mode which is superior over others. Whichever mode you're confident, which you've learned well, is equally good. It's just that you should be knowing what you are setting on the ventilator. So as already discussed, for sick babies, we usually start with assist control, or you may use SIMD along with PSV mode. VT or the target tidal volume. This is mostly if I don't know how much of you have a concept of that, the hybrid mode of ventilation that Anita ma'am just spoke about in her last few slides. So it just means it is a pressure controlled ventilation wherein you are setting a PIP, a pressure limit beyond which the pressure will not rise, but along with that, it gives you an advantage of setting a target volume as well. If you have set that target volume, whatever be the pressure, the ventilator will not let that target tidal volume to be exceeded for that baby. So what is the advantage with that? By setting a pressure limit, we are intending to avoid barotrauma. And by setting a target tidal volume, we intend to avoid volume trauma as well. So if we have the facility of volume guarantee or volume target ventilation, it will help us prevent both volume trauma as well as barotrauma at the same time. So this we talked about the mode and target tidal volume. So mode, for in all my slides you will see these are the same modes, because it is upon you to decide which mode you want to use. For sick babies, usually these two modes are used. Target tidal volume, it will be same for all the conditions. The target tidal volume in a newborn is 4 to 6 ml per kg. But we will discuss there are certain situations wherein we set in a slightly higher target tidal volume. For PIP and PEEP. PEEP, I think all of you know, as we have already discussed in the mode side, that PEEP is what prevents the alveoli from collapsing at the end of the expiration. So for most of the cases, it is set between 4 to 6. But in cases of a preterm lung, where the FRC is already low, there is a surfactant deficiency, we tend to start with slightly higher PEEP. By higher, I mean around 5. You don't usually start with a PEEP of 4 when you are ventilating a baby for RDS, because you do not want your alveoli to collapse at any cost. PEEP is set at around 5 to 7. Then PIP. How do we decide the PIP? So PIP is what we saw in the pressure time scalar. It is the maximum pressure which is reached during the cycle, during each respiratory cycle, which has to be set by us. So for most of the conditions, It will depend. Clinically also, you can judge PIP based on how is the chest excursion. So when you intubate a baby, you start doing ambo, you will have some rough idea that whether the lungs are stiff or the lungs can be easily ventilated. How much pressure you are requiring to getting an optimum or a just visible chest rise. Both excessive chest rise and minimal chest rise is bad. Just visible chest rise is something which we target. So your PIP should be based on that. Apart from that, you can first after once you have initiated, you can titrate it based on the X-ray and the blood gases. So on the X-ray, if you are seeing that the lung is well expanded, what do I mean by well expanded lungs? If you see that there are the right dome of the hemidiaphragm is at the level of the 7th to 8th rib. So that means your lungs are now expanded well and there are no retractions and there is a good chest rise. So that means your PIP and PEEP have been set adequately. Otherwise, you can titrate based on this. Moving on to rate. How do we decide rate? Now, in a preterm baby, we already discussed that there are short time constants. So compliance into resistance. Short time constant, lung is going to fill up early and empty early. So we usually ventilate a preterm baby with RDS on higher rates of approximately 50 to 60 per minute, and a TI which is set at around 0.3 to 0.535 seconds with an IE ratio of 1:2. For FiO2, again, for every condition, it has to be based on the SpO2 values and the PO2 values. In most of the conditions for both term and preterm, we will take these target saturation values as 90 to 95%. So you can, for starting, maybe if your baby on non-invasive was on an FiO2 of 40%, you can start at the 10 to 20% higher and then gradually titrate it based on the saturation and the blood gases. So this was about RDS. But for most of the conditions, you need to think about this only. Like when we talk of meconium aspiration syndrome, this would be one of the most difficult conditions to for ventilating in a newborn. Why? Because the pathophysiology is heterogeneous. There can be multiple mechanisms which might be contributing to the lung pathology in cases of meconium aspiration syndrome. Firstly, there can be chemical pneumonitis. The meconium has entered into the airway bronchioles. It is causing inflammation. It has caused a pneumonitis. Then that meconium can go into the alveoli, can damage the type 2 pneumocytes, and it can lead to secondary surfactant depletion. When the bronchioles, they block the airways, we know that their expiratory resistance is more. There can be air trapping. There's a ball valve mechanism, so the air is not able to come out completely. So that results in hyperinflation and air trapping. And we know that meconium aspiration syndrome is a risk factor for development of secondary PPH in babies. So whenever you have a baby with meconium aspiration syndrome, the ventilatory strategy will depend on which is the predominant pathology in your baby. But mostly we deal with a combo of all of these. So talking about the lung mechanics, it is a term maybe mostly compliance. If there is a secondary surfactant depletion, so it can lead to resistance of the compliance, reduction of the compliance. Resistance, if there is a hyperinflation, the meconium has blocked the bronchioles, there is an airway trapping going on. So it can lead to an increased expiratory resistance. Again, the time constant, because the resistance is increased, so that can lead to an increase in time constant, or it may be normal. Again, the FRC may be normal, there may be hyperinflation, or if the predominant pathology is surfactant depletion, then it may be decreased as well. So again, talking about the mode, I've already told you, assist control or SIMV PSC, whatever you want to use. Target volume, Usually in this, we target a tidal volume of 5 to 6. Earlier you saw it was 4 to 6. Here is slightly, I will not say higher, but you have to keep it optimized, because in cases of meconium aspiration syndrome, there is often a lot of dead space ventilation. So there is a lot of wasted ventilation, perfusion mismatch, wherein the gas exchange may be suboptimal. So try to keep a tidal volume at least around 5 ml per kg. Again, for PIP and PEEP, I have already explained you. PEEP, earlier it was said that CPAP or PEEP, giving PEEP is contraindicated in MAS. It can lead to air leaks, but it has been well proven that an optimum PEEP is necessary. So you can start with a PEEP of around 4 to 5, and you might even need to go up to 6 if you suspect that there is a surfactant inactivation. But giving surfactant will help in such cases. For PIP, don't go for very high pressures. Start with pressures of around 15 to 20. But often in cases of difficult cases of MAS, you may require to go even up to 25 or more than that PIP to maintain the CO2s in the target range. Rate usually, like it's a term baby. So we know that for term babies, we usually ventilate around 40 per minute. But what is important to be remembered here is that the TI should be kept around 0.4 to 0.5 with a rate of around 40. So basically, what we think is, what we intend is that there should be an adequate expiratory time, because we do not want any hyperinflation and air trapping, which will increase the risk of air leak. So you should ventilate these babies with a slightly higher TI and adequate TE. So moderate rates of around 35 to 40 will help you attain that. This is about the meconium aspiration syndrome, but if it is complicated by secondary pulmonary hypertension, then obviously we need to focus on the management for them. But often these babies, if there is a persistent hypercarbia or hypoxia, even at FiO2s of 100% or very high PIPs of up to 25, high frequency ventilation is often used as a rescue mode in these cases. Next common condition for which the baby might get ventilated is perinatal asphyxia. In asphyxia, there are two possibilities. One is wherein your baby is having central hypoventilation, but a normal lung. Obviously, the baby had refractory seizures or the respiratory drive is poor due to the insult to the brain, but you are obviously dealing with a lung which is a normal term lung, and we expect the compliance, resistance, and all other things to be normal. So we will just ventilate with the normal settings, starting with assist control or SIMD, target tidal volumes, slightly lower PIPs, around 10 to 12 should be enough. Moderate PEEP, for a term baby, a rate of 40 should be good enough. IE ratio of 1:2. But it is important that whenever you are ventilating such newborns, please avoid both hyper and hypoventilation, because we know they already have a damage to the brain, and cerebral blood flow is dependent on the CO2s. So they should not be, and they have a normal lung. So if you very aggressively ventilate them, then that might lead to hypoventilation and affect their cerebral blood flow. So take care of that. So maybe that you start ventilating for a hypoventilation, but then land up continuing ventilation for this baby because the brain drive has now gone. Next possibility in HI could be, it could be complicated by meconium aspiration syndrome or secondary pulmonary hypertension. Often these babies might have cardiac and renal failure, which can make them land up into pulmonary edema or acute RDS. So in this case, again, the ventilation strategy would be slightly different depending on the lung pathology. But the goal of ventilation is again normocapnia with adequate oxygenation. PPHN. It is not possible to cover PPHN in a single slide to cover the ventilation strategies for PPH. But I think to begin with, it is just important to understand that what is PPH, and we are talking about that it is a failure of the normal pulmonary pressures to come down or fall after the birth of the baby. It may be a primary BPH wherein a cause is not identified, or it may be secondary to many of the conditions that I've already mentioned. And herein your baby presents with severe hypoxemia with right to left intra and extra pulmonary shunts. But in case of PPH, we would be discussing today the lung mechanics and the ventilation strategies, but adjuvant therapies are more important, like correction of acidosis, keeping the baby calm, bringing down the pulmonary pressures by using vasodilators, and elevating the systemic pressures. So talking about the lung mechanics, it may be a term or preterm lung. If you have a baby whose RDS complicated with PPH, then it will be a preterm lung, otherwise term lung. Compliance, again, compliance, resistance, time constant may all vary depending on what is your underlying pathophysiology, which has led to the development of PPH in this baby. So the primary ventilation strategy will be based on that, but it is important to oxygenate them adequately and avoid any hypercarbia, because CO2 again would be a vasoconstrictor, a pulmonary vasoconstrictor for them. So do not, so usually we take a target CO2s of around 45 to 60 in the arterial blood gases for these babies, and a PO2 of around 50 to 60, 50 to 70 in the preductal gases. So mode and tidal volume, we have already discussed. PIP, PEEP, I think you must have understood by now. Most important thing here is that you keep the baby adequately oxygenated with a PO2s of around 50 to 70. In case, despite making the you're optimizing whatever you can, you are not able to achieve adequate oxygenation, you may try to bring down the changes in the ventilation in the following sequence. So we saw that oxygenation mainly depends on MAP and FiO2. Usually if you are already mean airway pressure, as we saw the formula, that it is PIP into TI minus PEEP into TE upon TI plus TE. So mainly your mean airway pressure depends upon the PWP or the P. When you saw the pressure times scalar, if we increase the P, then that is going to bring about a maximum change in your mean airway pressure or oxygenation. So I would suggest that the best variable to be touched upon first to bring about an improvement in oxygenation of a baby with PPH would be to slightly titrate the PWP. Maybe you can go in up to 7. You can see how the X-ray is, how the work of breathing is. And if that doesn't work, then you move on to the other variables like PIP. Because if you touch PIP or TI or the flow, rise time mainly depends on the flow, then all of these are going to affect your ventilation also. Ventilation is tidal volume into rate. So if you touch rate, it will affect your minute ventilation. It may lead to CO2 washout. If you tidal volume, we know mostly depends upon the PIP. Again, if you touch PIP, it may hamper your ventilation also. So just for oxygenation, PWP would be the best variable, but often it is a very, very difficult condition to ventilate. So adjuvant therapies like HFO, sedation, correction of acidosis, and pulmonary vasodilators might help. Moving on to bronchopulmonary dysplasia. So after MAS, I think this is the second most important condition, or one of the conditions wherein all the theories might fail, but it is a difficult condition to ventilate in a neonate, because again, the lung pathology is heterogeneous. It is an intermixture of the airway disease, of the parenchymal disease, and the pulmonary vascular disease. So there is a baby who has been ventilated for long, there has been barotrauma, there has been volume there has been biotrauma, there is a lot of inflammation in the lung. So there is a parenchymal disease, atelectasis, there are areas of hyperinflation, there is fibrosis, your airway might not be helping you, and often these babies have develop secondary pulmonary hypertension. So we have a preterm lung wherein the compliance is severely affected. There is an increased airway resistance. So time constant will vary depending on what is the predominant problem in your baby. Principles include adequate ventilatory support to establish optimum lung volume, recruit the alveoli well to promote even distribution, and avoid air trapping. So mode we are not going to discuss. Tidal volume, I would just like to make a comment in this, that keep it around 6 to 8. So this is one condition, as I told you, wherein we would like to keep the target tidal volumes at a slightly higher side. Why? Because the lung is severely damaged in these cases. There are areas where there is hyperinflation, there is a ventilation perfusion mismatch, there is a fibrosis. So there is definitely suboptimal gas exchange which is going on. There is a lot of alveolar dead space. There is a lot of airway resistance. So to keep the lung well inflated and to optimize the target. So the target volumes have to be kept slightly on a higher side. Even in severe BPD, we might even consider keeping the volumes up to 10 to 12. PIP is, you do not need to touch it mostly, 15 to 20 should be enough. PEEP is important. Again, here in the alveoli have the tendency to collapse. So there is an increased resistance. So it is important to keep the PEEP at a slightly higher side. So in a BPD baby, keep the target tidal volume slightly high with a slightly higher PEEP so that the lung is not deflated. It will help improve the expiratory mechanics. It will help in improving the gas exchange of the baby. And another important ventilatory strategy that should be in your mind is that in these babies, usually we keep a long TIs. Why long TI? As we already saw, time constant is compliance into resistance. Many a times resistance is very high in these cases of bronchopulmonary disease. There is tracheomegaly, there is airway resistance. So the lung is not going to be inflated easily. There is a lot of alveolar dead space. So we need to give more time to air to go in and fill in the alveoli. So we need to keep a slightly higher TI, but at the same time, you need to give an adequate expiratory time as well to prevent the air trapping and to prevent the hyperinflation. So how are you going to attain that? By keeping the rates low. So keep your rates low at around 20, 30 or maybe 40. Give a slightly longer TI and a TE of even 0.5 to 1 might be needed in cases of severe BPD. And this is one condition wherein we expect CO2s of up to 65 in arterial gases comfortably. Next, most of the conditions are like CDH or a pulmonary hypoplasia or a pulmonary air leak, less commonly encountered. But if you have some basic idea how we can titrate the ventilation, it might be helpful. So CDH, we all know, it is the failure of the diaphragm to develop normally, which can be isolated or syndromic. The lungs and the gut, everything is in the mediastinum. So there is pulmonary hypoplasia. The lung has not got the opportunity to develop well. There is a compromised cardiac function. And then when you start ventilating these babies, there is a distension of gut in mediastinum, again causing cardiorespiratory compromise. So the main problem in these babies are the lungs are very, very small. The compliance is poor. It is difficult to bring on a change in volume by giving pressure in these babies. Rest of the parameters might mostly be normal. So in these babies, There is pulmonary hypoplasia. Just remember, avoid giving higher pressures because already the lung is hypoplastic. It is prone to air leaks. It can rupture anytime. So try to ventilate at moderate pressures with moderate PEEP and target saturations of 90 to 95%. But often because there is hypoplastic lung, there is structural immaturity, there is dysmorphism of the pulmonary vascular bed. These babies often go on to requiring high frequency ventilation, so keep a lower threshold for that. Apnea of prematurity, again, it is one condition as we saw in HI babies, a normal term lung. This is a preterm baby with a normal lung mostly, wherein you have just ventilated because the baby is not breathing or the drive is not good. So ventilate at moderate settings of around 10 to 12 PEEP, PIP and 4 to 5 PEEP with slightly lower rates. Pulmonary hemorrhage. If there is a baby with coagulation abnormalities, surfactant inactivation, all of these can lead to hemorrhagic pulmonary edema. What is to be remembered is that we need to give slightly higher PEEPs to first, most important is to correct the underlying coagulation abnormality. But in strategy, ventilatory strategy, what is to be remembered is keep the PEEP on slightly higher side, and because there is a pulmonary congestion, so the air will need some time to reach the alveoli. So keep your TIs slightly higher and PEEP higher. That is all. Rest, the titration has to be done as already discussed. For air leaks or pneumothorax, pneumopericardium, pneumomediastinum, which we can, wherein there is an interstitial air collection, just remember that already the lung has ruptured and there is a pathological air in the outside the lung. So avoid giving higher peak pressures and keep what is the strategy for ventilating in a pulmonary air leak is that you ventilate these babies at a short TI with a higher rate. Why short TI? Because we do not want to give the air a long time to go and fill the alveoli and then enter the pathological space as well. So just keep your TIs short and to maintain the minute and also because we are not giving higher pressures, so to maintain the ventilation, because ventilation is tidal volume into rate. So if you are keeping the tidal volume slightly higher, so keep a slightly higher frequency to maintain the rates and drain the air. So this is just the last slide, what could be the suggested initial ventilatory settings, but I think we have discussed most of these. So just remember that ventilate only when required and as minimum as possible. There cannot be a single strategy for all babies. The initial settings will depend on the disease pathology. There has to be a dynamic adjustment in settings going on according to the development of complications. Choose a mode in which you are confident and lead to non-invasive as early as possible. Thank you. Any questions?
Thank you so much, ma'am. Good things are incomplete without seeking blessings and remembering our Lord. So now I request Professor Somshekhar Nimbalkar sir and all dignitaries as well as faculty members to please accompany for lamp lighting.
भैया हेलो, कंप्यूटर का वॉल्यूम बढ़ा है।
या श्वेत पद्मासना या ब्रह्माच्युत शंकर सरस्वती भगवती विश्वेश्वराया शारदा
Connect my things.
We now request all the respected faculty and delegates to please join us out for a small 10 minutes tea break. Please respect timings and be back within 10 minutes. Thank you.
Okay. Presentation नहीं चाहिए नहीं तक निकलेगा मुझे पता है पर ऐसे ही नहीं let me see that ये जो भी यहाँ लिखते हैं देना दिखनी चाहिए अरे ये दिख रहा है यहाँ दिख रहा है ऐसे कैसे नहीं दिख रहा है oh it's same okay ऐसे रहेगा मैं भी पीछे वाले सिस्टम देखने
ये दो लोग के सेशन रिकॉर्ड नहीं हो रहे। पेज रिकॉर्ड हो रहा है। प्रेजेंटेशन देंगे तो मदद करा सकते हैं। हाँ मैम, आप वो ये मेरे को आप प्रेजेंटेशन आपको मैं वाईफाई कनेक्ट नहीं करूँगा, वाईफाई का कनेक्ट नहीं होगा, तो आप एक काम करेंगे, प्रेजेंटेशन दे दीजिएगा हाँ, तो आपका वो मच कर देगा वीडियो
Recording or shadow of being a mail laptop, part of that
वाईफाई रनिंग डायग्नोस्टिक दिखा रहा है तुम्हारा। हाँ हाँ यस।
माइक की जरूरत है क्या?
नहीं जरूरत है।
हेलो हेलो बहुत बढ़िया, एकदम दोनों साइड पे भी है। इसको मैं पीछे डाल दूँ, it's not needed. I'll keep my iPad over here. हाँ। उल्टा करना ऐसे करना है।
इसके सपोर्ट में ऐसे रख देंगे, फीलिंग होगा
ऐसे नहीं, एयर है ना, मेरा भी पुराना है, 17 है, 17 कौन है आपका? सर का नया, सर का मेरा कनेक्टर सेम नहीं जाता। मेरे में बीजी है क्या? दोनों HDMI नहीं डाल,
लैपटॉप में।
हाँ सी टाइप होगा सर। तो मैं
आप मेरे को प्रेजेंटेशन दे दीजिए।
So welcome back all. So we hope better alertness after a sip of coffee. Without wasting much time, we shall move over for the next talks. So now for next talk, I would like to request Dr. Viraj Thakkar ma'am, who is in charge Chennai SIM, Akansha Hospital, Gujarat. Her first areas include functional echocardiography and point of care ultrasound and NRT. She is national faculty for various conferences and workshops and national NRP trainer. So over to you.
Are you all in? How many people are there outside? Any idea? So wish you all a very happy morning. And I would like to thank Central Zone Neocon team and this SGP for inviting me for this advanced ventilation workshop over here. As Dr. Somsekar sir mentioned, it is very difficult to compile everything and include everything in a day. Still, it's very nicely designed to cover most of the things. As he told, we had a workshop for entire 20 days, where 17 days were the online module. 1 day was the rest for traveling, and 2 days were entire 2 days. There were hands-on sessions at my place at Anand. So, point of telling this is it is that extensive thing. So here, rather than bombarding on the knowledge, I would like to have a bit of an interactive sessions. So it would be more fruitful to solve your queries. So this is regarding monitoring of the newborn on mechanical ventilator. Since morning, we have seen that various things, various modes of the ventilator, various disease specific ventilation, and I hope all of you must be doing ventilation. How many of you are already using ventilator? Is there anyone who have never used the ventilator in this workshop? No one, right? So whenever you put the child on the ventilator, you must be monitoring the babies on the ventilator. So this is a 39-week, 3.2 kg baby who has presented with the respiratory distress, and baby was intubated and was put on the mechanical ventilator on the PTV and VG mode. And now, if baby is on ventilator, then what are the things would you like to monitor? What are the things would you like to monitor? Anyone, please? Please answer. What would you like to monitor when baby is on ventilator? Shall I pick up someone or आप अपने आप से बोलेंगे? Vital. Great. So that is clinical monitoring, right? So you are going to monitor. Then ABG. So that is investigation. Then that's right. That's right. Again, medical monitoring. That's right. Okay. Oxygen saturation, pulse oximetry. Okay. Pulse oximetry. All no. Okay, pulse oximetry then. Any complications? Fine. So complication again, you are going to look for clinically, investigation by what? Chest X-ray, okay. Then that's it.
You can use USG.
USG of lung. Okay, USG. So that is imaging, right? So let's see that what all we can monitor. So definitely we need to monitor the patient clinically while we are standing by the side of the patient. Not only by looking at the patient, as she told, chest rise, but also we have to see the ventilator. Whatever parameters are being delivered on the ventilator, because nowadays we have a very high-end ventilators which tells you how much tidal volume is being delivered, how much minute ventilation is being delivered. Okay, so you have to look for the ventilator screen. Whatever things are being delivered, that is also is to be looked for. Then you have a pulse oximetry to check for your vitals. Then you have an ABG analysis, your blood investigation, and then you have an X-ray and sonography, as sir mentioned. Okay, anything else remaining? Let's see. So clinical monitoring is most important. Clinical is again look, listen, and feel. You are going to inspect what is the chest rise, how the baby is doing. Okay, you are going to oscillate the chest and you are going to palpate the pulses. And along with that, ventilator measurements. So most important thing is see the baby's comfort level, whether baby is comfortable or not. If baby is comfortable, then it is done. It's okay. But if baby is not under supported, then baby himself is going to travel to cope up in making the minute ventilation. And for which what baby is going to do? That is what is there. What is going to happen in making the minute ventilation? Tachypnea. Right? So baby has to start with the tachypnea. Okay, so there will be a distress, there will be an increased rate of respiration, and baby will try 2-minute ventilation. So if baby is not comfortable, then that means that there is something wrong. Your ABG is going to take a while to get changed. So your ABG may be normal, but baby may not be comfortable. So don't only go by the ABG. Clinical thing is most important. And what happens when the baby is on positive pressure ventilation? So how do you monitor? If you have ABG, definitely if your ABG is abnormal, then adjust the setting looking at the ABG. But if your ABG is normal, then don't think that it is okay. But if your ABG is normal, then don't think that the things are okay. Just look at the baby, and at what point of time it is most important to assess the baby. If baby is comfortable, then baby is well supported. But if baby is uncomfortable, then baby is under supported, and change the support of the baby accordingly. So clinical thing is most important. In case of high frequency ventilation, what are you going to look in case of high frequency ventilation? How many of you will use high frequency ventilation? Anyone can use high frequency? 2, 3, 5. So in high frequency ventilation, there is some kind of a vibration movement. So if baby is on high frequency ventilation, what you have to look for is the wiggle. So wiggle is should be up to the abdomen, and that is what you have to watch for. So the takeoff and assurance physical examination still remains the cornerstone of the medical care. Next comes the ventilatory parameter. So when you have a baby on ventilator, you are going to look at the ventilatory screen, and where you can see that what is the tidal volume being achieved, what is the minute ventilation, what are the flow graph and leaks. I'm not going to touch about the flow graph and leak because that is there in the next session by Dr. Kirti, but you have to watch for the tidal volume and minute ventilation on the screen. Then comes your ABG. So whether your oxygenation is okay, whether your ventilation is okay, there's 2 things you want to look for. And for that, you have ABG things. So in ABG, there are only 3 parameters which are going to be measured. That is pH, PO2 and PCO2. And there are certain parameters which are derived, and that is your bicarbonate, SO2 and base excess. And that is to be derived from this Cigar-Anderson nomogram. So I hope you all are ventilating a baby. You all must be aware about how the ABG is to be interpreted. But still, I would like to just revise, whenever there is a ABG, just first see that whether there is, what is the pH, whether it's alkalotic or acidotic. Then step 2, whether this alkalosis or acidosis is metabolic or respiratory. Okay, by looking at the CO2, looking at the bicarbonate level. Then step 3, check for the compensations. What is the CO2 and what is this bicarb level of? So check for the compensation, whether it's a compensated or uncompensated. And then step 4, check for the oxygenation. What is the PO2 level? Check for ventilation. What is the PCO2 level? And if there is any other abnormality. So this is how you interpret the ABG report step-wise. But how frequently shall we monitor the ABG? Is there any criteria? How frequently do you guys monitor ABG? You do monitor or you just do it by clinical background, clinical basis? 8 hourly, 24 hourly, 6 hourly. Whenever change the settings, okay, as per need. Fine. So ABG frequently you won't be able to monitor it. Going to have a blood loss. If your baby is on high frequency ventilator, there is so much change in the CO2. At that time, you sometimes may even require to monitor ABG at 2 hours interval. But it is really difficult and it consumes lot of blood. So there are certain known invasive monitoring devices. One is your pulse oximetry, which tells you about oxygen status. Another is your end-tidal CO2 monitoring, which tells you about your ventilation status. The another thing is transcutaneous CO2. Okay, and fourth thing is NIS, that is near infrared spectroscopy. So these four things are the non-invasive monitoring device. There are a couple transcutaneous oxygen and all those things are there, but these are the main four things which are there. So in that case, first of all, we are going to see about the pulse oximetry. So what is pulse oximetry? It is going to detect your oxygen level. We are learning pulse oximetry since long, even from MBBS time, pediatric time. So we have seen a lot about the pulse oximetry. That is considered to be the fifth vital sign. What are the limitations of pulse oximetry? When there is a hyperoxia, if the PO2 level is 300, what does the pulse oximetry show? Does it show you more than 100? Okay, so we don't have an idea about hyperoxia. When there is a hypoxia, the pulse oximetry detection will be quite late. And what about the CO2? You won't be able to judge the things from the CO2. Okay, so that is the main limitation. The another limitation is hypoperfusion and hypothermia. What happens in case of hypothermia? There will be vasoconstriction. And this vasoconstriction would hamper the pulse oximetry reading. Okay, and with movement also there will be artifacts. So these are the drawbacks of the pulse oximetry. Then comes your end-tidal CO2. So this will help you out in CO2 monitoring, just to help you out, because the carbon dioxide level was not being monitored with the pulse oximetry. So there's a one thing which comes as the end-tidal CO2 monitor. There are two different types of the monitor. I'm not going to go into detail. One is the mainstream and another is the side stream. And it both has its own pros and cons. But main limitations with this is whenever there is a lower perfused lung, so that will show less end-tidal CO2. And in case of obstructive disease, the CO2 level may be high. EtCO2 may be higher than the PCO2 level. Okay, because there is an obstruction. So it is there in the alveoli. So EtCO2 will be higher. In case of low perfusion, the alveoli are not being perfused. There is a dead space ventilation being happened. So your CO2 in the blood, PCO2 may be higher, while your EtCO2 may be low. Another problem with the EtCO2 is, in case of newborns, the respiratory rates are quite high. So, and another is, there is an uncovered tube. So there is a quite bit of leakage. So these two things are the drawbacks for EtCO2 being used widely in the case of newborn. Again, it can't be used for the high frequency ventilations. The third parameter of non-invasive monitoring is transcutaneous CO2. What is this transcutaneous CO2 and why can't we use? Because we have a continuous monitoring of the CO2. So looking at that, we feel that it's a very good thing. But what is there? It causes heating over the skin. It may lead to the burns. That is one drawback of the transcutaneous CO2. In case of impaired perfusion, in case of tissue edema, vasoconstrictor therapy, the TCCO2 reading would be different. And again, calibration will take more than 20 minutes. That is also a drawback. Okay. What happens here? The sensor are attached with the skin. This sensor, from this sensor, the heat is being generated. Here there is some heat element. So heat is being generated. And this, because of this, it increases the permeability of the CO2. So CO2 permeability for the skin increases. And this will lead to this. There is some electrolyte solution in this sensor, and that will turn the CO2 with the bicarbonate, with the water to carbonic acid, and that will change the pH. And depending upon the equation of pH and the relation between the pH and CO2, the CO2 is being detected by the change in the pH. So that is how transcutaneous CO2 works. It is good to have when you are ventilating the child in a high frequency ventilator, but as I mentioned, a couple of drawbacks of the transcutaneous CO2, it is not being widely used. Then comes your near infrared spectroscopy. I'm not going to go much into detail, but basically near infrared spectroscopy, there are NIR source, and there are two adapters, deep adapters and shallow adapters. So what it does the indirect assessment of the tissue oxygenation. Okay, how? Here, whatever oxygen demand is there and whatever oxygen supply is there. So there is a difference in the demand and supply. So balance of this is being judged real time. It provides a real time information about the balance in the tissue oxygen and demand, tissue oxygen demand and supply. But still, it is an emerging technology. And whatever normal values are there for this NIRS is yet not, it varies. For the newborn, we don't have much idea about the normal value. Basically, it has been kept for the two places, one is brain and one is the splanchnic circulation. So we have seen couple of non-invasive ones, but still the non-invasive monitoring can decrease the use of the blood gas monitoring. It cannot replace the blood gas monitoring. So we need to have invasive one as well as non-invasive. Both the things are required when we are monitoring the baby on the ventilator. So here we just have some exercise, because since morning we have seen that SIMV mode and SISPPV mode, and what is oxygenation, what is carbon dioxide level, what is ventilation. So let's look at the scenario where 27-week-old baby who is of 1 kg is on ventilator SIPPV mode. The ear pressure is 20/5, FiO2 is 21%, respiratory rate is 50 per minute, minute ventilation is 0.2 liter per minute, and SpO2 is 85%. If you look at the ABG, the pH is 7.3, PO2 is 40%, PCO2 is 45, and base excess is -1. So now tell me, what is the problem over here? Yeah? What is the problem? Yeah, hypoxia. Okay. So your oxygenation is just 40%. So problem is hypoxia. So how are you going to fix this? What is the solution for this problem? Increase the FiO2. Very simple over here. Increase FiO2. That is your solution. Okay, fine. So next case where there's a 34-weeker, 2 kg child. Here the child is on SIMV mode. Pressure is 18/5. FiO2 is 70%. Respiratory rate is 50 per minute. Minute ventilation is 0.12 liter per minute. SpO2 is 85%. If you look at the ABG, the pH is 7.2, PO2 is 40, PCO2 is 60, and base excess is -3. Now, what is the problem? Sorry? Carbon dioxide? More, high. Okay. So here PCO2 is high. Okay. Then oxygenation is low. Fine. So here the problem is O2 is less and CO2 is high. Oxygenation is the issue as well as ventilation is the issue. Both are issue. So what are you going to change? Which parameter would you like to touch upon when both the things are issue? Increase the, how are you going to increase the temperature? Which pressure is being increased? Right. So here the problem, you need to increase the PIP. What happens by increasing the PIP? You can increase the area under curve. So that is how you can increase the oxygenation, right? And here, what was the delta P? Delta P was this much only. By increasing the PIP, you have increased the delta P. So delta P has also increased. So that will help you out in increasing the tidal volume and improving your ventilation too. Great. The third exercise. The baby is 37-weeker and 3 kg on SIMV mode. The pressure is 26/4. The FiO2 is 65%. RR is 50 per minute. Minute ventilation is 0.3 liter per minute. SpO2 is 85%. And ABG shows pH of 7.3, PO2 of 40, PCO2 of 25, and D of -1. Now, what is the issue? Hypoxia is the only issue, right? There is no other issue. Is it the issue or is it not the issue? Hypoxia is the issue or not the issue? Yeah, this is the issue. It's going to damage to your white matter, and there are a lot of changes being happened with the PVL chances increases. So hypocarbia is hypercarbia, semi-hypocarbia is dangerous thing. So there is a low PO2 and low CO2. Both are the issues. Okay, O2 is low and CO2 is also low. These are the problems. What is the solution for this? How can we fix this? Everything's fine, yeah, increasing P. So here, what happened by increasing the PEEP? So this was the PEEP, and if you increase the PEEP, okay, so increase the area under curve, you increase the mass. So definitely you increase the oxygenation. The same time, the delta P decreases, okay, which was there before. So that will help you out in decreasing the tidal volume, and whatever high ventilation was there, that will help you out in fixing the CO2. So last and third exercise, fourth exercise, 33-weeker 1.5 kg child on SIV mode, pressure is 28/5, FR to 25%, respiratory rate is 35 per minute. Minute ventilation is 0.15 liter per minute, SpO2 is 91%, and ABG shows pH of 7.2, PO2 of 50, PCO2 of 60, and base deficit is -2. So what is the problem over here? Is there any problem or no problem? CO2 retention, yeah, CO2 is high, hypercarbia is the issue. So how can we fix this? Increase rate. Okay, why not increasing tidal volume? Pressure is already high and your oxygenation is not much issue. So that's okay. You can fix it by increasing the rate. So your rates were just 35. So by just increasing the rate, you can increase your minute ventilation. Okay, fine. So this we have seen regarding ABG, regarding non-invasive monitoring, and regarding clinical monitoring. Now this child was there on the ventilator with the high pressures as you mentioned before, on 28/5 on SIPPV mode, and oxygen level is 74%. Suddenly goes down. Then how are you going to approach this child? You are monitoring the child with a ventilator. Oxygen saturation is 74 now. Low, yeah. Low. Okay, right. This is very good thing about this auditorium, because hardly few of the auditorium would have had the mic at the audience level, isn't it? So you are also been given a fair chance to talk loudly. मेरे को तो बिना माइक के भी मैं इतना loudly बोल रही हूँ, है ना? So of course the patient who is on ventilation, and there is acute deterioration, displacement of the tube. So again, your clinical monitorings, you have to check where the tube was positioned. The position of the tube is proper or not. Okay, if there is any obstruction to the tube, you need to do the suctioning. If there is a PPOD, pneumothorax, how are you going to look for the pneumothorax? By X-ray. And is there any other means? Huh? Transillumination. Before X-ray, you have things in your hand as transilluminations. Always do clinical things, the handy things first, and then only go for the investigation. And equipment failure. So you have to check for the equipment failure too. And sometimes there may be two issues. Like there might be a pneumothorax and there might be some displacement, there might be a leakage in the circuit, something would have gone wrong. So both two issues can also be there. You found the pneumothorax and still the baby is not improving. So then there might be another issue. Sometimes you found the equipment failure and still baby is not improving, then there might be pneumothorax. So keep your eyes open, keep your ears open, and look, listen, and feel. Right? So this is imaging of the baby, and here you can see there is a line. Okay, there is some pneumothorax. So how frequently do you monitor X-ray in this child? Any child, not in this child, any child who is on ventilator. Do you monitor it every 24 hourly? Shall we monitor every 48 hourly? Before and after intubation, or shall we monitor before and after extubation? What should be the frequency of X-ray monitoring?
Before and after intubation. No need for before and after intubation. Before intubation. You decide intubation from the X-ray. Right? After intubation, why is it monitoring the X-ray? ET2 position. Is there any other way to monitor ET2 position? Let's look at this. Okay, so X-ray exposure is going to give you one chest X-ray is going to give exposure of 0.008 to 0.03 MSV radiation. And if there is an abdominal X-ray too, then the exposure increases by 1.5 to 2 times. And that is approximately a natural radiation exposure in a year for any patient or any adult. Okay. So how much exposure we are going to give about the radiation to a newborn by repeatedly monitoring the X-ray. So the X-ray ideally should be monitored as reasonably less as possible. Okay. So how can you limit this exposure? By using the ultrasound if possible. Okay. But problem with that, you have to be trained in getting the ultrasound done. But you can call a radiologist to get it done. You should be aware about what are the things you want to look for. It's not necessary if you are not trained. You can tell your radiologist, but you should be aware that ये चीज आपको यहाँ पे ultrasound में दिखती है, and you can use even ultrasound for the same. Don't get the X-ray for TTN patient. If you're clinically suspecting that there's a TTN, then there's no need to get the X-ray. Avoid exposure from there. Okay, use the ultrasound. This is a picture image of the ultrasound where you can see that this is the pleural line, the white line is, and this all are A lines. These are a normal lung ultrasound. Okay, and this is a simple B line. Generally, there won't be a B line, but this simple B line is also normal thing. This is the simple B line. The first is simple B line. Okay. Second is here you can see that, it's not like the lines, it's almost confluent B line. Everything is clubbed together. There are confluent and in between there is a rib shadow. So this is a confluent B line, in between there is a rib shadow. And in the third image, that is the image C, everything is together. There is no even rib shadow in between being visualized. Everything is, this is a compact B line, So this is a complete white out line. So ultrasound is also being used in a couple of studies for deciding about the surfactant, whether to give surfactant or not in case of RDS. There is an RDS scoring, and we are not going to go much into detail about the same. Okay, but you should be aware that these are the modalities which are available. So this is a complete RDS lung where the ultrasound is look like white out lungs. Okay. So you can also use the ultrasound. Where are the things you get the X-ray? You get the X-ray for checking the line. All the invasive things, ET tube, your PICC line, your UVC line, just to check the position of the line, you have to get the X-ray done, right? But you can also get it done in the ultrasound. So this is again an ultrasound where you can see the UVC tip in IVC. You can see this UAC tip in aorta. Okay, you just put a 3 o'clock position probe in this subposterior region, and just look for the aorta, look for the IVC, and you can see the tip of the catheter in either UAC, in either aorta or inferior vena cava. Okay, this is the aortic arch view where the ultrasound probe is kept at the cerebral position in the suprasternal region. So you can look this aortic arch. This is the aortic arch. Okay, and these are the branches. Okay, and here against that second branch, somewhere over here, you can see the ET tube. You can see the ET tube. So you can also use the ultrasound to visualize the ET tube. There are a couple of studies being done for the same, but unfortunately, the sound and presentation to this air tube is poor. So that is why it is not widely being used to look for the ET tube positions. You usually need to get the X-ray done to check for the ET tube position. Whereas the X-ray is being done, pneumothorax, right? To check for the air leaks. Not only the pneumothorax, pneumomediastinum, pulmonary intestinal emphysema, everywhere you are going to check with the X-rays. But emergency, definitely for the air leaks.
So can we replace this ultrasound for the, can we replace ultrasounds for this X-ray? No? Yes or no? How many are yes? Any one of you have done ever done the ultrasound or are doing? Great. 3, 4, 5. Fine. So you can use the lung ultrasound and for air leaks. And it has, the studies have shown that it has very good sensitivity and specificity for detection of the pneumothorax, almost 100% specificity and 80% sensitivity for detection of the pneumothorax. Where you just need to look for is lung point. So lung point we'll see in the next slide. But here what you can see is the sliding is absent. I don't know. Yeah. So sliding is absence of the pleural sliding. Okay. And then there will be a barcode sign and lung point. So here it is a barcode sign. Okay. This is a sliding. Then the next is barcode sign and lung point. Fine. Yeah, this is the lung point. Can you see this is a very sharp line? And here, can you see this kind of a thing? So this is the starting, okay, of pneumothorax. So that is the lung point. So you can see the lung point, you can see the absence of pleural sliding, and you can see the barcode sign as soon as you put the M mode over it. Barcode sign is being visualized. If you put the M mode, if you put the M mode, then only you'll see the barcode sign. Okay. And some congenital problems like the CDH where you have to check for the X-ray. So after X-ray, one most clinical important thing is pain assessment, which is mostly being neglected. Okay. So whenever the child is on ventilator, one should assess the pain. And if we look at the studies, though I have been told not to include studies much, but only 1 or 2 have included, that it tells that invasive, this is a very old study, which shows that invasive mechanical ventilator in infant appears to be associated with the chronic pain and stress. And this was supported by increased endorphin level. Beta endorphin was high for the patients who was on mechanical ventilator. So definitely it's going to give stress to the baby. And this stress can lead to impaired motor and cognitive development at 8 months and 18 months of the corrected gestational age and ultimately later on the developmental issues. But what is the problem with assessment of the pain? So main thing is this, there are no specific tools available, which is a universal. And even the judgment is quite subjective. It is many a time imperfect. And there's a poor correlations between the individualized tools that are being used for assessment of the pain in the newborn. Okay. And even if somebody has done the scoring system and has decided that this baby is in need of the sedative, then the sedatives, sedative safety is yet not been proven for the certain sedatives have an issue as far as it's being used in the newborn. So this is a study published in 2020 and which has concluded, this is a systemic review which has taken 20 studies, and this has concluded that no explicit evidence can be obtained to support the use of one proper scale for the pain assessment. That doesn't mean that it is not to be done, but which is to be done is yet not clear. But the inference was that comfort and the NPAS was the score which can be used to judge or assess the need for the analgesia in patients with the mechanical patient who is on mechanical ventilator. And PIPP and CRI scores can be used for the acute and post-operative pain or procedural pain. So this is what can be used. That is what their their conclusion was. And these are the different scale systems, which again, I'm not going to go into detail. You can read it out. Here we are not for the pain assessment mainly, but there is a PIPP score, that is premature infant pain profile, where the heart rate, oxygen saturation, facial actions, these are to be considered, and the scoring system has been derived. The another score is the NIPS, that is neonatal infant pain score. The third one is the NFCS, that is neonatal facial coding system. And here is our NPAS, which we can use for the patient who is on mechanical ventilator. And that includes neonatal pain, agitation, sedation scale, and that includes crying, irritability, facial expression, extremity tone, and vital signs. Okay. There are other pain scoring systems are there, that is cries, comfort scale, and then, which again you can go through by yourself. And whenever there is a pain, even if you just do the scoring system, if you decide that the baby is in pain, the first and most important thing before going for the sedation is the known pharmacological measures. And these known pharmacological measures are oral sucrose, swelling the baby, giving a kangaroo mother care to the baby, containment, facilitated tickling, and reduction of the environmental sensors like the noise and light, along with giving a best music or intermittent music therapy to reduce the pain. This has a good effect for reducing the pain. So take home message over here is, in spite all the invasive and non-invasive monitoring, physical examination remains the cornerstone for the medical management. ABG may be normal initially when baby is trying to compensate to maintain the minute ventilation. Non-invasive monitoring decreases the need but cannot replace the ABG monitoring. Lung ultrasound can decrease the need for the X-ray exposure and is 96 to 97% a specific handy tool for detection of the pneumothorax. The time for detection of the pneumothorax has decreased by 15 minutes in one of the studies by using a lung ultrasound against the chest X-ray. And fifth point is, there is no universal pain score available, but NPAS can be used for mechanically ventilated baby for assessment of the brain and toning test. Thank you. If you have any query, questions, we can discuss it out. I think organizers are your. Should I invite after that, I shall use the
Welcome all faculty and delegates to this prestigious Central Zone Neocon and State Neocon Uttar Pradesh. हमारे प्रदेश में जो न्यूनतम मॉर्टेलिटी है वो कम होने का नाम नहीं ले रही है। इनफैक्ट पिछले सर्वे में देखा गया 1-2 पॉइंट में बढ़ ही गई। 93 से 96 में मैं KGMU के NICU इंचार्ज देखता था, वहाँ पे एज ए पूल ऑफिसर था मैं। इट इज इक्वल टू असिस्टेंट प्रोफेसर डॉक्टर मलिक के साथ। तब PGI में NICU नहीं था। यहाँ के रेजिडेंट्स फैकल्टी के बच्चे डिलीवर होके वहाँ ट्रीटमेंट के लिए रेफर होते थे। गायनी डिपार्टमेंट नहीं था, डिलीवरीज यहाँ नहीं होती थी। तो बहुत सेक्रीफाइसेस के बाद यहाँ पे NICU अब इस स्टेज में है। वी आर टॉकिंग ऑफ रिड्यूसिंग पेन एंड इंटैक्ट सर्वाइवल। सो आई कांग्रेचुलेट ऑल द पीडियाट्रिशियंस, न्यूरोलॉजिस्ट हु स्टार्टेड दिस। 1980 में बड़ी मुश्किल से न्यूरोलॉजी बनाई गई थी, जो डॉक्टर प्रोफेसर भार्गव ने बलरामपुर में, जिन्होंने जो सफदरजंग हॉस्पिटल दिल्ली में 60 साल पहले हम लोगों ने बताया था गवर्नमेंट को कि पीडियाट्रिक्स अलग चीज होती है। डॉक्टर पीक मिश्रा ये कहती थी। तो वहां से यहाँ तक की जर्नी हम लोग कट डाउन बिना एनेस्थीसिया के कर देते थे, क्योंकि पेन नहीं मिल रही है। अब पेन रिडक्शन और इंटैक्ट सर्वाइवल की बातें हो रही है। तो हैप्पी लर्निंग एंड कांग्रेचुलेशंस अगेन। थैंक यू वेरी मच।
I would like to congratulate HGPJ team for conducting this advanced workshop, and I am elated to see this good attendance here, and also happy because there's a mixture of students, teachers, consultants, and I hope you get at least some points from here and you apply them in day-to-day practice. Basically, the main aim of the workshop is to get the practical knowledge. Theory is already there in the books, but my message is only that take at least few points and apply it in your day-to-day neonatal care. I wish you all the best, and we hope to see you tomorrow in full numbers. Okay, thank you.
I request all the faculty to come on the dais for one photograph, please.
After that, all
All delegates can please come forward for a group photograph.
हम नीचे चलेंगे हम नीचे
भैया इसका कम करो यार, बहुत महंगा है।
Now I would like to heartily welcome our mentor and super guide, Dr. Kirti Naranje ma'am, Head of Department of Neonatology, SGPGIMS. Ma'am is Educational Committee member of International Newborn Brain Society and Clinical Expert member for State Technical Advisory Unit for Sound Management under UNICEF. She has over 40 publications in both international and national pioneer journals and has been a state faculty for pediatric COVID-19 training of doctors. Over to you now.
So a very good afternoon to everyone. So I'll topic for next this session is about the ventilator graphics, how we can use this graphics in especially in the monitoring of babies or who are on invasive ventilation. So I'll be covering my talk under the following headings: why the graphics are important, and there are two basic types. One is the scalars and loops. We'll discuss in details about the common scalars and loops that we can use for monitoring the baby on ventilator. Interpretation of normal graphs, then some abnormal graphs, and if time permits, we can discuss some cases also. So why do you need to monitor graphics? So how many of you have the ventilators where the graphics are displayed and you actually look into it, the mechanics of lung when you're ventilating a newborn baby? Anyone? Why do you need to monitor? Yes, you can use the mic on.
Hello,
Hello.
ma'am, we are using monitoring graphics and our setup regarding troubleshooting and leaks for leaks.
Okay, one can use it to look into leaks, and yeah, that's very good to that you know. But why you? What additional information did they give that the other things or your clinical monitoring will not tell you? Yes, you want to.
The effort of the baby can be seen in the graph.
Yes, we can also get a look how much efforts are clinically भी देख सकते हैं, and you can calculate also in terms of magnitude also through the graphics. और किसके लिए use कर सकते हैं हम graphics? Anyone?
Pulmonary compliance.
Okay, one can look into
Any
compliance.
obstruction can be visualized. Any obstruction can be assessed.
Very nice, very good. One compliance के लिए हम देख सकते हैं. Anyone else?
For monitoring deterioration or recovery.
Yes, we can. If we look at the serial trends of the graph, we can look whether the baby is deteriorating or. Yes, very nice, very good. Or so many of the points. I think we have a learned audience over here. So most of the points are like for monitoring the. First thing is we look for the monitoring the function of the ventilator. We also require graphics to look for the patient's response to the ventilator. And based on these, this will help you to adjust your ventilator settings according to the patient's needs. So like you have to fine tune your ventilator settings, and then also allows us to use, interpret, evaluate, and troubleshoot. We have a station on troubleshoot. So graphics, you will see there that it is very important to look into the graphics to know where you are like stuck or where is the problem, whether in the patient or in the ventilator, in the troubleshooting the ventilator and patient's response to the ventilator, right? So, so why? But you must have seen in the ventilator there are so many numbers also written. Tidal volume भी आता है, minute ventilation भी आता है, right? Resistance का भी कुछ value लिख के आता है, compliance का भी value लिख के, तो हम तो वो भी देख सकते हैं, right? And we also have to look into that also. So what is the advantage of graphics? Anyone? So कभी भी आप numbers हमेशा याद नहीं रहते, right? Whenever you see a picture, it fits into the memory and it is easier to understand. So always the graphical representation of data is more easy to interpret as well as more easy to remember. And serially आप numbers बार numbers भी नहीं देख सकते, याद भी नहीं रख सकते. लेकिन अगर आप एक बार graph देख लो, image देख लो, वो आपको समझ में आता है कि यार पहले तो ऐसे था, अभी उसका ऐसे हो रहा है. So in that way, graphical representation is always a better way, and it is easily understandable and remembered, right? So there are many parameters like we have already seen in the previous lectures. The measured parameters are the flow, pressure, and the time. And the rest are the calculated from all these measured parameters are the volume, which is an integration of flow, then compliance, resistance, all these are compliance, resistant, work of breathing, and other things like autopsy, flow, active exhalation, etc. are the calculated parameters. So measurements of flow and pressure are done through different instruments like flow sensors. If you do not, the basic requirement of getting graphics is you require something to measure the pressure, something to measure the flow sensors. Flow. So for flow, we have flow sensors. So if you do not have these in your ventilator integrated, you will not get graphics. So flow sensor is very important. So whenever you want, without flow sensor, the graphics have will not be generated and they will not be properly be representative of patient's conditions, right? So there are different types of flow sensors. One is if you have used on SOFI ventilator, there is a called as a pneumotachometer, where it senses depending upon the pressure difference. And then there are hot wire anemometer. I'm not going into details of the flow sensors type. We can discuss it at the stations. Then main thing is there are two ends where the flow sensor can be put. One is at the patient end, which is beyond the Y-piece. So at the just beyond the Y-piece near the endotracheal tube. This is the patient end flow sensor, and this is the ideal one because if and another one is at inside the ventilator or at the ventilator end. So because ideal one is at the patient end, because just after exhalation, if we sense that is a true representative. If we sense at the ventilator end, there are a lot of circuits and also all that can compound the your graphical generation, right? Then pressure can be measured at endotracheal tube in the at the Y-piece, then at maybe in the esophageal probe, and then inside the ventilator. So the uses of graphics can be broadly mainly divided into for the ventilator circuit related abnormalities, patient and abnormalities in the patient or in the lung mechanics and their interaction, right? So for these three purposes, main broad purposes, we can use graphic ventilator graphics are used. So there are two types of waveforms. Ones are the scalars and another ones are the loops. So scalars and loops are graphical representation of data. Whatever the numbers you are seeing on this, they combine or and we can generate the graphical representation of the data, which is generated by the ventilators. So coming to the scalars, so scalars are nothing but the waveforms which are generated when you plot any parameter against the time, right? So waveform representation of pressure, flow, and volume versus time is your scalars, right? So the time is on x-axis, and if you want to measure the pressure is on the y-axis, flow on the y-axis, and volume on the y-axis. So this is how you can get the pressure time scalar, flow time scalar, volume time scalar, right? So anything against, when you're plotting against the time, is your scalar. And loops are the two variables which are plotted against each other, right? So one variable of pressure on x-axis and volume on y-axis, or volume versus flow, or flow versus pressure. So you can make a loops of that. So two parameters against each other are loops, and any parameters against time is scalars, right? So coming to the scalars, the commonly used scalars in graphics that we see in our day-to-day practice are the flow time scalar and the volume time and pressure time. So these three are the main. And each waveform has to be assessed in the terms of magnitude, what is the duration, and how is the pattern. So I'm not going into much more details about identification of modes because we have already discussed in the modes of ventilation. But in broadly, the parameters which you are controlled. So if you are looking at the scalars, like these three graphs shows like pressure time scalar, flow time, volume time scalar. So you can identify the pressure modes and volume modes broadly by looking at the parameters which you have not set, right? So if you are using pressure control mode, you are controlling the pressure variable, right? So that will be constant. And what will be changing is your volume, right? So in pressure mode, if you can see that your pressures are constant and your volume is changing cycle to cycle, right? In volume modes, your volume will be constant and your pressure can be changing from time to time. So grossly, you can look into this and determine what variable you are controlling. First scalar, like we will be discussing in details, is the flow time scalars. This is the flow time scalar which is generated in the volume mode. It is easier to understand in volume mode, the graphics. So first we look at the main things, and then we can also have graphics from the pressure modes, right? So the flow time, this is only for understanding purpose, right? So for the flow time scalar, flow is plotted on the y-axis and time on the x-axis, right? So in volume mode, the flow time will be looking like a square wave form like in the inspiration. So you can see this point is the beginning of inspiration. Once the flow starts from the ventilator, it rises rapidly to a peak. So this is the peak flow, and the flow is sustained for some amount of time. Okay, that is the inspiratory time. During the time, it will be constant, and then from this point, it will rapidly drop to zero, right? And then this is the end inspiratory pause. And then there is a beginning of exhalation, and exhalation is mainly the passive process, and it is mainly determined by the patient's lung mechanics, right? And this is the peak expiratory flow, and then there is an exponential decay of expiratory flow during the exhalation. So this is how a flow time scalar and the components of the flow time scalars will be looking on a volume mode. There are different shapes of the flow time scalar. Commonly are the rectangular or the square waveform, which is the mainly seen in your volume mode. Then the sinusoidal pattern, ascending ram and descending ram. Descending ram is mainly with your pressure modes, pressure control modes of ventilation, and then exponential decay. So rectangular and the descending ram pattern are the most commonly seen flow time scalars. So in this, the square wave flow pattern that we have already seen, in this, the inspiratory flow rate remains constant over the entire period of your inspiration. And the expiratory flow is determined mainly by your elastic recoil of your respiratory system and the resistance of your airways, right? This is the deaccelerating ram. Like we have seen this, this is mainly in pressure control mode. You can see that in this, the inspiratory flow rate deaccelerate as a function of time to reach the zero flow and at end inspiration, right? And in this, for a given tidal volume, for this kind of shape of waveform, the inspiratory time is always more as compared to the square wave pattern, right? The abnormalities that we can see in this flow time scalar is one is like whenever there is an increase in resistance in your airways, like an obstructive airways, or your endotracheal resistance can be at your patient's airway or at the endotracheal tube. So there can be a prolonged expiration. So that you can see that unusually prolonged expiratory phase of can be determined in this scalar. Also, this is used to determine the auto peep. Auto peep is how you identify in the flow time scalar is like when your expiration doesn't reach the baseline and your inspiration begins. So this is how you determine, because there is some air trapping which is occurring. So your inspiration is beginning before all the air your air can be exhaled out, right? Another is inadequate inspiratory flow. When your flow settings are not good or there is a lot of pressure efforts which are there, you can see some kind of serrations in your inspiratory part of your flow time scalar. And also sometimes there is an excessive effort. There can be a peak overshoot like this or can like this. So that means your inspiratory flow is not adequate. So in this case, the patient is having more of a flow hunger kind of thing. So these kind of thing can be seen with inadequate inspiratory flow. So the main uses of the flow time scalar are mainly patient related, where you can determine the prolonged expiration airway obstruction. Also, you can determine if you have given some bronchodilator therapy or you have cleared the airway, the response can be seen. Also for looking for air trapping, we can determine the break time, we can determine the flow waveform type, and also know that whether your flow rate is adequately set or not, right? Flow starvation that we have already seen. And then obviously, if there is a problem, there is an asynchrony or the triggering effort, this also can be determined with the flow time scalar. The next is the pressure time scalar. The pressure time scalar, before we go into the normalities, how it is generated, you understand this, that how the pressure time scalar is generated, then it is easier to understand. So there are three components for generation of a pressure time waveform. One is your airway pressure. Three things that you need to understand: basic circuit of the ventilator and equation of motion for the respiratory system. So there are two components for the airway pressure. Airway pressure is composed of two pressures, like for easier understanding. One is the resistive component. What is the resistive component? The resistive component is nothing but the resistance which are generated, or the pressure which is required to overcome the resistance of your airways and your endotracheal tube. The elastic component is nothing but your elastic recoil of your lungs and chest, right? So these are the two pressures a ventilator has to generate to overcome, so that it can deliver the adequate breath, right? So the resistive pressure depends mainly upon the diameter of the airway or the endotracheal tube and the airflow. So resistive pressure is there is a flow into resistance, right? So this is a resistive pressure, and elastic pressure depends upon volume and stiffness of lung and chest wall. So जितना भी stiff lung होगा, ज़्यादा elastic pressure होगा, right? So the formula, the elastic pressure is basically volume upon compliance, right? Compliance is volume, delta volume upon delta pressure. So if we rearrange the equation, the elastic pressure is your volume upon the compliance, right? So the total airway pressure is resistive pressure plus elastic pressure. And if we put in the formula, you will get a formula and you can calculate it. This is how the ventilator calculates. We need not calculate, but we should know because we get a ready-made. If you put your flow sensors and pressure sensors, you will get that value, right? Now coming to the basic ventilator circuit, the ventilator circuit is just not the outside part. It is also your human body also has a natural ventilator, right? So there are two parts. One is the ventilator with its piston, and our own body's respiratory system with diaphragm as a piston. So right. So this is the basic ventilator circuit. It is just not the outside thing. So we have to consider the inside body thing also. And the equation of motion is nothing but the total airway pressure that we have already seen is to move the air into, or to give a effective breath inside the lung. You have to the ventilator has to generate sufficient pressure to overcome your resistive component and the elastic component. So that is your equation of motion, right? So how the pressure time scalar is generated, we will understand using the volume mode, because this is easier to understand, right? So whenever the ventilator begins to give the breath, so the piston moves down. So first component which he has to overcome is your resistive component, right? Because there is an endotracheal tube, then there your airway, then your lungs, right? So the initial part of your scalar is represented by the resistive component. So जो पहला part आपका spike होता है ये वाला, this is the airway resistance, right? The pressure which is required to overcome the airway resistance, right? Then it will slowly rise. It will go to the terminal bronchioles and then your different type of alveoli. So not all alveoli are open at one time, right? So they are एक पहले इधर का खुलेगा, फिर उधर का जाएगा, फिर उधर का जाएगा. So that's why you get a steep rise. So and this becomes your peak airway pressure, right? So once all the alveoli are open, then that becomes your peak airway pressure. So at this time, there is some drop in the pressure. अगर आपका flow zero कर देते. Suppose if you give inspiratory pause in that, or your inspiratory time is not properly set, this flow ends here abruptly, and then there is some drop. So at this point, so आपका एकदम से drop हो गया. So अगर आपका flow बंद हो जाता है, if there is no flow, there is no resistance, right? So flow has to be there for the resistive component. So अगर आपने flow कम कर दिया तो resistive component निकल गया. तो ये जो बचता है, this is P plateau, right? So P plateau is nothing but the pressure which is required only to open the lungs. It does not have resistive component, right? So it represent only the pressure which is required to open all the alveoli of the lung, right? So these two things are important to understand: the peak pressure, the resistive pressure, and the plateau pressure. So plateau pressure is to open the lungs. The resistive pressure is to overcome the airway resistance and the endotracheal tube resistance, and the plus of both is the total air peak pressure, right? So ये आपको समझ गया तो आपको पार्ट में the pressure time scalar के generation आपको पता चल जाता है, right? So if there are only airway increased pressure, the resistive pressure will increase. So this is the normal graph. So if only the airway resistance is a problem, then this part will be more, right? And if there is a decreased compliance, the P plateau will be more, and the P resistance will be less, will be normal, right? And the peak pressure, in both the cases, the peak pressure will be more, because in total, sum of both will be more. So if any component is more, the peak pressure will be more, right? So that is how you can determine what exactly is the problem. Is the problem of compliance, is the problem of resistance. So you can get into this. But this kind of classical waveform is only seen with the volume mode of ventilation. If you are using a pressure time waveform, using a deaccelerating ramp flow pattern, or in the pressure control mode, because you are controlling the pressure. So this kind of P plateau and P peak we will not be seeing with the pressure control mode. So in this case, you can just simply see this kind of waveform. And if you are using a PEEP, the baseline will be above. So if you are using a PEEP of 5 or something, the baseline will be above the 5 mm. And you can see the inspiration and the expiration. In pressure time waveform also, we can see some of the abnormal forms. Like first, this is a normal one. So first thing is, in this case, whenever there is a high initial pressure spike, which reflects airway resistance and flow settings. So this can represent the high airway resistance. So अगर कभी भी a high airway resistance आता है, there can be some spike of increased pressure, and as the flow declines, the pressure drops eventually. Then there is a low compliance state. Then if there is a low compliance state, the desired pressure which we required will be achieved, but it will take slow time. So it एकदम से नहीं बढ़ेगा, जैसे यहाँ पर एकदम से बढ़ा है. So there is an increase in rise, slowly बढ़ के, that at the end of inspiration, your peak pressure will be achieved, right? Also, we can use pressure time scalar for looking at the whether the flow is adequate or not, right? So in case of adequate flow, your breath will be smooth. In case of inadequate flow, if you set the flow too low, there will be initial scooping in your pressure time scalars. So this is how you can determine. So mainly the pressure time scalars are to look for the compliance and resistance problems. Also, there are other things like asynchrony, triggering effort, flow adequacy. You can also determine with the flow time, pressure time scalar. Next one is the volume time scalar. In this, this is the volume time scalar. You can see this is inspiration and then the expiration. This is the peak inspiratory tidal volume. So this is your tidal volume. The peak is your tidal volume. Volume time scalar can be used to look for the leaks. Leaks in this case, if you see this, there is inspiration, then there is expiration. But your graph will not reach zero, will not touch zero, and there will be sudden drop, right? So expiration mein aapka sudden drop hoga, so this can be considered as a leak if there is a leak. Other use is about looking for the active exhalation. In active exhalation, your expiration will reach below zero. So this is your active exhalation. So patient continuously exhale करते रहते हैं, तो फिर आपका graph नीचे आ जाता है. Then volume, uses of volume again, looking for the breath type, active exhalation, leaks, also tidal volume, how the waveform shape is. Then coming to the different types of loops. So loops are most commonly we use is the pressure volume and flow volume. So for the pressure volume loop, one is used mainly to determine whether the breath, how we can determine in the pressure volume loop whether the breath is mandatory or spontaneous. So mandatory breath in the pressure volume loop is like the firstly on a ventilator initiated mandatory breath, the movement of PV loop will be counterclockwise. So अगर आपका ये inspiration है, ये expiration है, so it is a counterclockwise loop. So in that case, it is a mandatory breath. So this is how mandatory components of mandatory breath in PV loop we can discuss this further. So this component is once your breath starts, the alveoli starts to open and it reaches the peak inspiratory pressure where your all the alveoli, and this is the pressure which is required to open your airway to overcome the resistance of your airway as well as open the alveoli. So this part is your inspiration and the expiration is your this part, which is passive and determined by your elastic recoil of chest wall and the lungs, right? The if you see this dotted line, this is a condition, this is a straight line which can be, which is represented, which represent the basically when there is no airflow, then the straight line will be occurring in the PV loop. If we plot pressure and volume without flow, then this can be there. This line, this will be a straight line. The difference between this is the trans airway pressure. This is your airway pressure, and this represents your dynamic compliance. The slope of your PV loop determines your dynamic compliance, and this straight line determines your static compliance. Static compliance is only on the lung alveoli. Dynamic compliance also includes your resistance, right? So spontaneous breath कैसे होगा उसमें? Spontaneous breath अगर हमने देखा PV loop में, it will be clockwise, right? And mandatory breath was anti-clockwise. So we can see, we will see the PV loops, how it looks like in conditions of decreased compliance and increased airway resistance, right? Work of breathing for a spontaneously breathing patient, there will be initial spike in the, because spontaneous breaths are negative pressure breaths, right? What we are breathing is a negative pressure. We are not a positive pressure breath. So आपका graph आपका negative side में भी आएगा, right? So the work of breathing, if there is a lot of work of breathing, this effort of patient can be seen to the left of the vertical axis. And this is commonly addressed by instituting the flow trigger, right? And then how does the assisted breath, like मतलब अगर patient triggered breath है तो कैसे दिखेगा? Patient trigger है तो पहला वो जो breath लेता है वो negative रहता है, तो there is a negative spike, and then there is inspiration and then expiration. So शुरुआत में clockwise, then counterclockwise, right? So what happens during the states of decreased compliance? तो जो भी आपका PV loop है, वो आपका decreased compliance में क्या होगा? It will be shifting towards the right side and downwards, right? So you can look, this is a normal compliance PV loop. In the decreased compliance, your PV loop will shift downside and right side. And when your conditions improve, it should shift to the normal. Or if there are states of increased compliance, the opposite will occur. This is how it looks in the pressure control mode, and this is how it looks in the volume mode. More or less same, but in pressure, it is more of a squarish pattern, and in volume, it is more of a leaf-like pattern. In PV loops, due to increased airway resistance, there will be increased hysteresis. What is hysteresis? Nothing but the difference between this inspiratory part and the expiratory part. वो ज़्यादा बड़ा होते जाते हैं, मोटा होते जाते हैं या squarish होते जाते हैं, तो there is an increase in airway resistance, right? So as the resistance increases, loop becomes wider. So an increase in the expiratory resistance is more common, And in inspiratory resistance जब हो सकता है जब patient bite कर रहा हो या there is a kinking. So I think then the coming to the other uses to look for the over distension. So over distension it may आपको ऐसे beaking जैसे दिखता है. That means if by further changing your pressure, the volume doesn't change, right? So आप pressure क्यों बढ़ाते हो कि आपका tidal volume बढ़ना चाहिए और oxygenation improve होना चाहिए, right? लेकिन एक stage ऐसे आ जाता है कि आप balloon को फुगाते जाते हो, but वो और मतलब फूकता तो है बट आपका वॉल्यूम इतना बढ़ता नहीं है बल्कि थिन होते जाता है. देयर इज अ चांस ऑफ एयर लीक, राइट? सो दिस काइंड ऑफ लीकिंग if you seen, that means it is a or you are reached the state of over distension. Then over distension can also be determined with the this compliance C20 by C dynamic C20 divided by C, right? Dynamic compliance. If it is less than 0.8, then it suggests over distension, right? So this is your what is C at the end of your point is your compliance, right? Dynamic compliance. The C20 is when if you divide this loop by 20%, and then this is at the 80% of your distension, right? If you might if this is 100, this is 80, so this becomes 20%, right? So if this at this point you look at the compliance, at this point you look at the compliance, right? And then divide it. So if it is less than 0.8, it is suggestive of your like it is just going to give it up, right? So you have to overcome, you have to stop, like you have to decrease the pressure and adjust your loop. Then another important concept with the PV loop is about how you titrate your PEEP based on your PV loop. So once the ventilator starts giving breath, the small alveoli starts opening slowly, and at some point of time majority of your alveoli has opened up and there is a steep rise in the your curve. So this point is your lower inflection point, and similarly during exhalation, which is passive, the alveoli starts to collapse, but at some point suddenly most of the alveoli starts to collapse, and it is again a steep curve. So this is the upper inflection point. So nowadays, this is a dynamic PV loop and this is a static PV loop, that is at the state of no flow. So at this nowadays they say that you have to set your PEEP at the, around your upper inflection point, so that to optimize your ventilation and titrate your PEEP for mainly for the oxygenation purposes, right? So upper inflection point is currently is what is said that you should titrate your PEEP up to. Then your flow volume loop, mainly the components of flow volume loop is that flow you plot in y-axis and volume on the x-axis. This is inspiration and this is expiration. Some of the ventilators can also show like reverse, like expiration above and inspiration below. So it depends upon what ventilator you are using. This is your mainly the peak inspiratory flow, and this is your peak expiratory flow. The uses of flow volume loop is mainly to look for your obstructive airways. So whenever there is an airway related, there is increased airway resistance, the exhalation will be slow, and there you can see this kind of scooping in your exhalation part. And when you give a bronchodilator therapy, you can see the it normalizes. So you have to also into the peak expiratory flow. The peak expiratory flow will be less. This point is peak expiratory flow, and when you give your bronchodilator therapy, the expiratory flow obviously increases. Then it will also be more. Then the leaks can be identified when your expiratory part ends on doesn't go to zero, right? It ends before zero on the x-axis. So if you see this kind of loop, this is a I think this is a leak. And then auto PEEP, when your loop doesn't end but end on the y-axis, not zero, so this is your auto PEEP. So the flow volume loops can also be used to identify auto PEEP and leaks. Then airway secretions in the circuit. So in airway secretions, what you can see is there is a lot of serrations if you, this is a normal, the yellow one is a normal, if there is sedations or there is a lot of water in your circuit, because there is a lot of sedations in your expiratory part. So you have to, it is not a smooth, that's it. So these are the major waveforms and loops that we have seen. So what waveforms you should be observing or analyzing? The waveforms which you are not controlling. So the waveforms which are dynamic for the current ventilator settings. So if you're using the pressure mode, then you should monitor the volume and flow. If you're using the volume mode, you should monitor the pressure and the flow time scalars, and obviously they are your loops. So to summarize, this is a table that we can discuss later. I think we can discuss the cases at the station. So I'm just going to skip this. So the key messages are the ventilated graphics are used to identify patient machine related factors and their interaction. Flow related graphics, that is flow time and flow volume loop, identifies the problems that we have discussed, like autopy, airway obstructions, and response to therapy. Pressure related graphics are useful in identifying changes in compliance and resistance. PV loop is used for identification of optimum pressure for ventilation and assessing the work of breathing. So thank you everyone for joining, and I must take this opportunity to congratulate all the fellow Indians for the Chandrayaan landing that we are so excited about. Thank you. Thank you so much.
So thank you so much, ma'am, for simplifying such a difficult topic on pulmonary graphics. So now I would like to request our respected senior mentor and guide, Dr. Abhijit Roy, sir, who is the first house of our lineage, who passed first AM neonatology batch of our prestigious institute and currently working as assistant professor in the Department of Neonatology. He has special interest in neonatal hemodynamics and developmental supportive care. He has been the organizing secretary of our recent neonatal echocardiography workshop, and he has many national and international publications. Over to you, sir.
Good afternoon, everyone. Thank you, Fazia, for such kind introduction. So we have learned till now there is aspects of neonatal ventilation, and now we will learn about the weaning and extubation. So we'll talk about the why weaning is important, then what is the natural course of a baby on a ventilator, and then we'll talk about the weaning strategies, the extubation checklist and timeline that we need to follow, and then a case scenario about the difficult extubation. So as we know, that ventilation has been boon for some babies, but then it can also quickly turn out into curse because of repeated reintubations or prolonged duration of mechanical ventilation, which can lead to a ventilator-associated lung injuries. So we need to reduce these. There is no consensus about appropriate way how to wean the babies. Either delaying the weaning or either weaning too early, both can pose risk, and therefore understanding the natural course of the disease is very important. We need to weigh against the risk of deterioration of the ventilator and also in case of difficult intubation. So this is how our respiratory journey of a extremely premature baby proceeds. So, immediately after the delivery, baby is stabilized on delivery room CPAP. Then we might get the baby surfactant using LISA or initial, and then thereafter we can stabilize the baby on CPAP. In some cases, the baby might need to be intubated. In that scenario, we need to give a tidal volume of 4 to 6 ml per kg, and then the baby can be subsequently extubated to CPAP or HFNC. This is usually in the early phase of RDS. Then, suppose if the baby is continued to ventilated, then we move into the evolving phase of BPD, which is from the day 14 of life to 36 weeks of post-mutual age.
Most of the time, the causes of the failure include either sepsis, NEC, or PDA. Majority of the times, we encounter these situations very frequently. Then, supporting aids can be either systemic steroids or diuretics. Then, further, the child can go into the established PPD. And most of the time, the reasons are different. There can be background PPHN, there can be poor nutrition to these babies, there can be airway anomalies. And the definitive treatment that can be given are the use of steroids, diuretics, sildenafil, chest physiotherapy. So in this scenario, we need to reassess the respiratory airway as well as the parenchyma. We can proceed with the tracheostomy, and some of the babies might require long-term ventilation. So these babies can be extubated to HFNC, CPAP, or NIPT, depending on the situation. So what is weaning? In weaning, we give the control from the ventilator, the respiratory control of the baby from the ventilator to the baby. So it is, and for that, smooth transitioning, we have to be vigilant. Early weaning helps in reducing the risk of nosocomial sepsis. It helps in reducing the patient discomfort and need for sedation. Minimize the development of oral aversion, and therefore it helps in development of oromotor stimulation and subsequent minimization of the feeding difficulties. It also helps in promoting the parental bonding and development supportive care. Various strategies have been employed for weaning, which includes the permissive hypercapnia, in which the PCO2 levels are kept between 45 to 65 millimeters of mercury. It helps in reducing the ventilator-associated lung injury by providing lower tidal volumes, giving lower PIP, and this helps in better cardiovascular stability, providing there is better cardiovascular stability, there is better ventilation perfusion matching, the mismatch is minimized, and also there is smooth ventilation. Various studies have been done, which showed that, like Felby and support study, which showed that practicing permissive hypercapnia beyond 65 millimeters of mercury might not be that beneficial. Then permissive hypoxemia, that also can be practiced, but then from various trials like Neoprom, which comprised of the meta-analysis of 5 studies, it showed that the saturation levels which should be targeted is between 91 to 95 for both the term and the preterm babies. Then we should have weaning protocols. One study showed that 36% of the ICUs only have weaning protocol, and so all over the world, not many ICUs and ICUs are not having the weaning protocols, which we can employ. Adjunctive therapies can also help in reducing the duration of mechanical ventilation, such as caffeine, which can help. Caffeine, we know that it reduces the duration of mechanical ventilation need for. It reduces the duration of mechanical ventilation, and also at 2 years of age, it can help in improving the neurodevelopmental outcome. Diuretics, which can be used cautiously, helps in prevention of the BPD. And then not all the PDA should be treated, but those babies on mechanical ventilation who have hemodynamically significant PDA on case-to-case basis, these might require either medical or surgical correction. Then avoidance of sedation and nutritional therapy, which forms the backbone of any NICU, and prevention of osteopenia of prematurity. Then chest physiotherapy, use of systemic steroids, as we have learned through various meta-analysis. The recent one from the Ramaswamy et al. From 2021 suggests the use of moderate dose of dexamethasone, 2 to 4 milligram per kg over a period of 10 days is but helps in extubation. Then use of intratracheal steroids, which can help in facilitating the extubation, but at the cost of mortality. So that also has to be weighed. So how do we define that the child is ready for extubation? So these babies should have the respiratory drive. They should have minimal distress, and the underlying disease process should be resolving. These babies should be hemodynamically stable, and there should be minimal inotrope support or either no inotrope support. The baby should be on the peri-extubation settings, which is already decided. Then there should be appropriate mental and neuromuscular status with minimal or no sedation, as already talked. The child should have appropriate acid bush status. The hemoglobin should be appropriate, and there should be no dyslipidemia. So parameters of blood gas with prior to extubation, the pH should be more than 7.20. We should remember that permissive hypercapnia should not be practiced within first 72 to 96 hours, because it can lead to IVH. Not only the high levels of PCO2, but also the fluctuations in PCO2 can also lead to IVH. So permissive hypercapnia is best avoided in initial days, and thereafter we can practice permissive hypercapnia. Then we should see that there is no metabolic acidosis in the blood gas, and the hematocrit is optimized. So there was this study based on the lung ultrasound and echo parameters, which help in predicting the extubation. So this was done in the RDS babies. You can see there was scoring in the 6 zones, and depending on 6 zones of the lung, which included the anterior chest wall, right upper and right lower, left upper and left lower, and then in the axillary areas on the 2 sides. So zone 0, in which we can see the A lines, as I had already told. Then score 1 was given for those babies, those zones with the B lines. Then score 2 was given for acute interstitial syndrome, which comprised of the confident and compact B lines. Then zone 3 was given for the underlying consolidation. So it was found that lung ultrasound sonography can predict the extubation success in preterm infants with RDS, especially in those babies who had lung scores less than 10, and those with more than 10 had difficult extubation. And also the left ventricular eccentricity index can help in prediction and help in determining the pulmonary artery pressures. So which mode should be preferred? As we have talked that not all the modes have much advantage over each other, but volume target ventilation is definitely may help in accelerating the weaning. Then there are other modes such as pressure support, SIMV plus pressure support, and then SIMV alone. These modes have one and the other have side benefit only. SIMV plus support might have some benefit over the SIMV. So we should always attempt early weaning. Physiologically, as I told, volume guarantee is better than the assist control, and then which is in turn is better than the pressure support ventilation standalone, which in turn is better than SIMV plus PSV in terms of weaning, and then SIMV more alone. As we know that oxygen is harmful, can cause toxicity. So FiO2 should always be weaned first in comparison to PIP. And as ma'am had already told, we should try to change only one parameter at a time, so that in case of worsening of blood gas or in case of increased work of breathing, it is easier to regain the stability. So one of the most important point is that we should remember that pH determines the expiratory drive, and it is not PeCO2. So we can tolerate permissive hypercapnia in babies. We should, but initial days we should avoid increased rise in PCO2, which is more than 65 millimeters of mercury, or increased fluctuations in PCO2 during the initial days. If there is an increase in, if we want to increase the PCO2 for practicing permissive hypercapnia, we can decrease the PIP and rate. And if we want to decrease the PO2 for permissive hypoxemia, we need to decrease the FiO2, and we should not decrease P less than 5. So the setting should be decreased every 4 to 6 hours, and PIP should be reduced in units of 2 to 3 centimeters of water, and FiO2 should be weaned from 5 to 10% every 4 to 6 hours. Then PEEP can be reduced by 1, but it should never be reduced below 5 because of physiological issues. And then the rate should also be weaned. Most of the time I see in NICEs is that we are not weaning the rates, so that should also be weaned. Inspiratory time should be kept between 0.3 to 0.4 seconds, and we should reassess using blood gases as and when needed. So the ideal peri-extubation settings include a PIP of 16, which can it can be even smaller in the preterm babies, which can be between 12 to 15. PEEP should be less than 6 centimeters, and rate should be around 30. FiO2 should be around 30%, and resultant map for term babies should be 8 centimeters of water, and for preterm babies it should be 7 centimeters of water. And some babies with the BPD might need to be extubated from the higher settings. So this is how proceed weaning in a baby who is on the pressure control ventilator. So the child can either be on SIMV plus PSV mode of ventilation, or either the child can be on assist control or pressure support ventilation. So these babies, once the saturation is in the normal range for 94% for the term babies and 91% for the preterm babies, we should start decreasing the FiO2 first in units of 3 to 5% every 15 minutes. Then if the child is comfortable, there is no tachypnea, no work of breathing, there is not much work of breathing, and PSU2 levels are within normal range, then we should start decreasing the PIP once the FiO2 has reached to 40% in 1 to 2 centimeters of water. Then blood gas should be repeated every 30 minutes. Once the acceptable blood gases have been reached, so for example, platelets is more than 7.25 and PCO2 is between 45 to 65 milliliters of mercury without any prominent metabolic acidosis. Then suppose our child is on SIV plus pressure support ventilation, then we should continue weaning the PIP further until and FiO2 alternatively till the PIP is about 20. And once the PIP is less than 20, then we should start weaning the rates also. And if the child is on assigned mode and already the pressure support ventilation is not added, then we can add the PSV also. It should be roughly around 30 to 50% of the PIP minus PEEP. And we should ensure that the tidal volume generated from the spontaneous breath should be at least 4 ml per kg. Then subsequently, we should reduce the PEEP if it is high, more than 5, but it should never be less than 5. Then we need to reduce the, we can further reduce the rates. And once the rates have been, then we need to check for the child is spontaneously breathing. Then we should have a extubation checklist, and we can give the spontaneous breathing trial. So what is spontaneous breathing trial? In this, the baby is put on the ET CPAP, so endotracheal CPAP on the pre-extubation settings, and the child is kept for 5 minutes and rise either if there is a fall of SpO2 less than 85% or there is bradycardia that is less than 100% on increasing the FiO2 up to 15% from the baseline, and still there is fall, then the test is considered failed and the child cannot be extubated. But using spontaneous breath test is controversial. It should not be used in every baby, and especially for the extreme preterm babies, in which cases it can do more harm. So once the checklist has been ticked, we can extubate the baby either to a CPAP, HFNC, or non-visible ventilation, and IPP. Then if the child is on assist control ventilation, similarly, we have to wean the PEEP and FiO2. And if the child is on pressure support ventilation, standalone, then we should see that there might be increase in work of breathing. In that scenario, we need to increase the FiO2 because the PI can be too short and it can lead to atelectasis. Once the PIP has been reduced to the agreed settings and the rates, backup rates are reduced, then we can extubate the child. So now moving on to the checklist and the timeline. So once the child has achieved the pre-extubation settings, so at before 24 hours, we need to discuss with the clinical and nursing team. Extubation should be planned and well documented. The setting should be decreased and sedation should be stopped at least 12 to 24 hours prior. Hemoglobin should be optimized. It should be under control. Caffeine, if not already should be started. Then hemodynamic stability should be ensured, and reasons for the prior extubation failure should be evaluated. Then the family should be informed Then we can consider using the dexamethasone, which can be given 4 hours prior to extubating the child. The dose is usually 0.25 milligram per kg. It can be given 8 hourly, 3 doses. And then at the beginning of the shift, so the staff nurse, the unit should be well equipped, and there should be a mix of experienced nurse and who should be well skilled also. So again, the extubation can be planned in the morning prior to rounds. 2 hours before the extubation, the child should be evaluated by the clinical team, and optional changing to PSV can be done, and SBT is also optional. Then feed should be stopped, and if there is no IV cannula, the child can be put on the IV fluids. IV cannula can be put and put on IV fluids. Then 1 hour prior, the machine should be kept ready. Either the mode of extubation should be pre-decided, whether you want to extubate the child on CPAP or HFNC or an IPP machine. Then it should be kept ready. The interfaces should be arranged, and suction of the endotracheal tube in the nasopharynx should be done. Then RB should be checked if the fluids are already stopped. Then 30 minutes prior, you should assess minimal handling should be done in the patient care, and necessary handling should only be done, such as diaper change. We should check the position of the OG tube. Then senior staffing should be present. So once you have decided to extubate the child, the baby is more than 28 weeks of gestation. These babies can be extubated to the HFNC or CPAP. None of the one mode has the benefit over the other. In babies less than 28 weeks of gestation, CPAP is the preferred mode. And those babies who have required ventilation for prolonged duration, in these babies, NIPPV can be given. So once the child has been extubated, the child can be kept home or sweated to it. Also, we can ensure that the pressure is not lost due to mouth opening. The pacifier can be used, and we can send the blood gas after 1 week. So post-extubation adjunctives include caffeine nebulization with the epinephrine, which can be done in the dose of 0.5 ml per kg. Maximum of 5 milligram can be used. Then diuretics can be used, chest physiotherapy should be done, and inhaled or systemic steroids can be used, and ongoing monitoring and evaluation should be continued. So some of the babies might require reintubation also. We have to look for the signs of whether the signs of increased work of breathing is there, or there is frequent apnea are there, or there is increased in FiO2 requirement, which should be pre-decided. Suppose if you decide to reintubate the child on 60 or 70% of FiO2 requirement, then if the child is requiring more FiO2 than that, then the child should be reintubated. And if there is persistent respiratory acidosis, then also the child needs to be reintubated. So at many times we find difficult scenarios, such as the baby is on baby is having severe BPD and is stuck on the ventilator, and we are not able to wean these babies. So in that scenario, that typically we should give higher tidal volumes, as Akanksha have already told, about 7 to 12 ml per kg. Higher feeds might be required for this baby, and with higher TI and ventilating at a lower rates. So we need to optimize the growth for this baby. Higher calories are required. We need to manage the osteopenia prematurity. Anti-reflux medication can be given, such as domperidone, and then fluid restriction can also be done. Then we need to optimize the neurodevelopment, such as an ISO environment has to be controlled and minimal sedation has to be given. Then the baby should be stabilized on the steady respiratory support with optimal PEEP, increased expiratory time for reducing the auto PEEP. Then BPD spells should be addressed, and we should have VAP bundles to prevent ventilator-associated pneumonias. Then PPHN should be avoided, or either it should be treated. So after the baby has reached the post-menstrual age of 36 weeks of gestational age, we can give higher levels of oxygen, 94 to 98, because oxygen itself causes vasodilation in the pulmonary circulation. Sildenafil can also be used. So suppose the baby is improving, then we can contemplate extubation, and we should slowly wean this baby to NIPPV. But if the baby is not improving, then we can consider the bronchoscopy or virtual bronchoscopy. Suppose the child is having frequent BPD spells, in this scenario, the bronchoscopy can be considered, or if there is no improvement, then echocardiographic for pulmonary artery pressures assessment. CT MRI can be done with virtual bronchoscopy. Tracheostomy can be done, which reduces the work of breathing, and there is better oromotor development and neurodevelopmental outcome. Multidisciplinary team approach with the help of the ENT specialist and nutritionist can be done, and nurses can be done. So the take-home messages would be: you should plan your weaning immediately as soon as you intubate the child, and there should be once the child achieves the minimal mean airway pressures in FiO2 requirement, we should start weaning the child. We should have a checklist for extubating the child, and the success depends on the multidisciplinary pre and post extubation plans. And the most important thing is nutrition, which forms the backbone of an ICU care. Thank you.
सर आपने बोला कि ऑक्सीजन के बाद पीआईडी को लेटेस्ट वर्जन तक ले जाने के बाद ही रेट जो है 5 बीट्स पर मिनट के हिसाब से कम करना चाहिए।
हाँ जी, you should
5 बीट्स पर मिनट के हिसाब से कम करना चाहिए, वो भी घंटे की बात करना चाहिए।
हाँ जी, you should try to wean every 4 to 6 hours. हाँ, मतलब that is convention, depends on the situation of the baby.
और जो सब टीप है, टी डबल टीप वाला, वो less than 5 4 whether generally
Usually it is not physiological, it can lead to atelectasis or increased work of breathing. So we do not recommend keeping the PEEP less than 5.
और CPAP की
CPAP के लिए भी ये हुई।
जैसी कम हुई और T5 के आए तो आप CPAP भी लगा सकते हैं।
हाँ, mostly 5 से नीचे नहीं देना चाहिए। Unless and until there is pulmonary interstitial emphysema, कोई other issues are there, only then you can decrease the PEEP. Yeah, there is significant air trapping.
So thank you so much, sir. The next plant of an HFO will be discussed on workstation. So proceeding further, I would like to invite Dr. Abhishek Paul, sir, who is currently working as assistant professor in the Department of Neonatology, SGPH IMS. His thought areas include functional echocardiography and focus. He has numerous national and international publications. So over to you, sir.
So thank you, Fazia, for the kind introduction. So my topic is on use of nitric oxide in neonates. So the specific learning objectives of this talk will include history, one of the animal experiments which was done to prove the basically the mechanism of nitric oxide, introduction to nitric oxide, mechanism, indications, time of initiation, steps in initiation, and then at what dose the engine has to be started, how do you how do you see the response and failure, escalation of any duration, weaning, discontinuation, some trials and take homes. So the beginning, so it started from the Alfred Nobel. So this nitroglycerin molecule, it was originally synthesized by Sobrero, and then it was used by Alfred Nobel to manufacture dynamite. And then from this came the invention of this nitric oxide, which is the also called as the endothelial derived relaxing factor. So this was one of the experiments done by Professor Lakshmi Simha, which was published in Pediatric Research in 2009. So there, this graph shows various curves where there was a resuscitation done with 21% and comparison with 100% oxygen. So this is a this DH is dihydroethidium. So it was tested on this one DSP is 1 day old spontaneous breathing fetal lambs. So it was tested, and then gradually the fetus was exposed to 100% oxygen and then 100% oxygen plus nitric oxide. So as you can see in the picture, the third picture where the 100% oxygen is used, there is a thickness at the pulmonary arteriole. So 100% oxygen giving is detrimental. And as you see in the next slide, which is when you add nitric oxide to 100% oxygen, there is a tremendous decrease in the thickness of the pulmonary vasculature. So I'll just brush through these slides in view of paucity of time. So the IMF was approved by the Food and Drug Administration in 1999, and it has been the mainstay of treatment for PPHN in newborns, and it has also been shown to reduce the need for ECMO. So as we all know, it is a selective pulmonary vasodilator. It usually affects the pulmonary vasculature instead of the systemic vasculature. So this is the mechanism of action. So L-arginine is the amino acid, and with the help of this nitric oxide synthase, NOS, this nitric oxide is produced. Then this nitric oxide gets diffused from the endothelial cell to the smooth muscle cell, and thereby causing the relaxation. So this is the actual mechanism of action of nitric oxide. So there are other mechanisms also, like it decreases inflammation, it decreases vascular leak, It preserves the vascular endothelial growth factor expression, and it also alters your gene expression. So coming to the other mechanism, so usually for the appropriate action of nitric oxide, you need a appropriately recruited lung. So here from this diagram, you can see that NO preferably goes to the ventilated alveolus as compared to a non-ventilated alveolus. So this effect is known as the microselective effect. So the take-home message from this slide is that NO has a microselective effect. It usually will go to your ventilated alveoli as compared to the non-ventilated alveoli. So these are the approved uses of nitric oxide, PPHN, and where there is confirmed PPHN and the gestation is more than 34 weeks. Or if the oxygenation index is more than 25, even people have used a lesser oxygenation index where it is come back to around 15 to 20. So always the oxygenation index doesn't have to be 25 in order to start nitric oxide. And the third is good for 60% oxygen. If you have to maintain, if you are trying to maintain the pre-ductal saturation more than 90%, usually the optimal dose is 20 parts per million. And we have to take into consideration some conditions in which there is a caution or we cannot use INA. So these are congenital diaphragmatic hernia, left ventricular dysfunction, or there is hypoplastic left heart cell. Also in asphyxia and sepsis, you need to be cautious. So these are the indications of using in three terms. Not much evidence is there, but you will consider in those preterm infants in which there is a history of prolonged rupture of membranes and there is PPHN physiology plus echo evidence. So these two I have crossed because early hypoxic respiratory failure without PPHN is not an indication to use NO, and it has no prevention of BPT. So this guideline came from the American Heart Association and the American Thoracic Society that it can be beneficial for preterm infants with severe hypoxemia that is usually due to PPHN physiology rather than parenchymal lung disease. So appropriate time to start is over 25. I think the steps in initiation can be discussed in the workstation, so I'll just skip it. The starting rate is 5 to 80, but most of the RCTs have started with a dose of 20 parts per million. And usually, if you don't get a response at 20, it has been shown that you will not get a response even if you increase it. So how do we assess the response? So response is assessed by, so there is a classification which from Goldman et al. Who had classified patients into responders and non-responders. So what is the definition of a responder to IN? Where the PaO2 increases by 20% and there is a fall in the OR after 30 minutes of starting IN. So basically the responders were classified into three categories. One is early failure, then the second was sustained responders. So the first is, so the examples I've just highlighted in black that what are we called? Usually babies who have early failures are babies with CDH, pulmonary hypoplasia, secondary to oligohydramnios. And in the sustained responder group, usually the babies had MAS, meconium aspiration syndrome, PPHN, and RDS. The third category of babies are into prolonged dependence who require nitric oxide for a prolonged period of duration for more than 2 to 3 weeks, and even it can be extended to 6 weeks also. But most of the babies died in this group, as studied by Goldman. So when do we call failure? As we discussed, as it has been discussed in the earlier lectures also, that how do you assess the oxygenation of a newborn whenever you are starting on the baby on a ventilator. So we see the A by A ratio, that is the arterial by small a by capital A ratio. If it is less than 0.22, it defines that this is your NO is not working. You can still go incrementally up to 80 ppm in like diet conditions, but usually it is very unlikely that you will get a response at this high dose of nitric oxide. So toxicities is usually methemoglobinemia and formation of nitrogen dioxide, which is a more toxic molecule as compared to NO. So if the levels of methemoglobinemia rise to more than 10%, then you have to temporarily discontinue the nitric oxide. And likewise for NO2, if the NO2 concentration rises to more than 5 ppm, then you have to temporarily withhold your nitric oxide system. And there are chances of bleeding, particularly in the preterm. So when we escalation, as I told you, we can go to maximum 80, but there are risks of methemoglobinemia. So this slide, as I already told you, usually the optimal dose and the maximum dose is around 20 only. So the duration is typically 5 days. If you are requiring nitric oxide for more than 5 days, then we have to investigate for other causes also. And the maximum duration of INO, what has been studied in all the trials, has been around 14 days. So how do you wean? So the starting, as I told you, the starting rule, you can just remember two rules are there. So the 20-20-20 rule, that is for initiation. And initially the rule was 60-60-60, but the research from Professor Satyan in 2015, the rule has changed to the 30-60-90 rule. So if there is oxygenation, so it is for 60 minutes, and then if the FiO2 is coming down to more than 60%, and your SpO2, which is measured by pulse oximetry, is more than 90, then you can gradually cut down on the iron. This is one of the other strategies of weaning iron, like from 20 parts per million to 15, 10, 5. And once you come down to 5, every 4 to 6 hours, you reduce by 1 ppm until unless you reach 1, and then from 1 you can gradually discontinue the nitric oxide. So this is the recent weaning approach published by Souvik Mitra from Canada. So after clinical response, iron will be weaned by 50%, provided the oil is less than 10. The pre-ductal SpO2 does not decrease by more than 5%, and the FiO2 is not increasing by more than 10%. So we should avoid abrupt cessation of NO because it can be counterproductive, and then again there can be rebound hypoxemia. So when do you discontinue? When the FiO2 requirement has come down to less than 60%, and your PaO2 on the blood gas is more than 60, and there is no evidence of rebound pulmonary hypertension. And if the increment FiO2 has been more than 15%. So this is the summary of INO use. This is the summary of INO trials. So as you can see that this is a forest plot, and the red and the diamond, that is the summation of all the trials. So it has been shown to reduce the need for ECMO and whenever it has been used for PPHN in newborns. So this is a bubble diagram showing the same thing, that there was increment in the oxygenation index and decrease in the death. So one of the recent studies showed that NO can cause cancer also. So the take-home messages is this INO improves the oxygenation and decreases the ECMO use. So evidence is start on at 20 ppm until unless there is a real need, then only you escalate, because the more you escalate, the problem with methemoglobinemia comes. And only it has to be done in centers where ECMO facilities are there, because already the oxygenation index is high, and you can land up in a situation where the oxygenation index can easily go to more than 50. So which is a clear-cut indication of initiation of ECMO. So there is an increasing evidence of INO, but still more papers have to come in order to validate this use. And also it has been shown that iron is an anti-inflammatory therapy, but still this thing has not come into routine practices, more for research studies. Thank you.
I'm not sure whether I did
No, it has to be done, yeah, usually because in non-ECMO center, it has to be done with caution.
Centers do not have iron facilities, have iron facilities, have iron facilities. So the
Why do you, because the baby is already critical stage. So
That's an ideal situation. That's what he's talking about. That's an ideal situation.
Whenever the big studies are there, start with the 25, but I guess.
So the
That is what we do, like start early, lean early, and get be the fire. But over 15 is now considered to be a relatively aggressive. Is the threshold has decreased from 25 to 50. So that.
Thank you so much, sir. So before lunch, I would like to inform you all that there will be 4 workstations post lunch, and 10 delegates will be there in each station. Now I request everyone to proceed for lunch and back to your respective workstations within 30 minutes.